jointly organized by the Departments of Prosthodontics and Oral and Maxillofacial Surgery at the Guru Nanak Institute of Dental Sciences and Research in collaboration with the IQAC and the Alumni Association of JNITSR. Proudly supported by the GIS Group and Noble Biocare as our esteemed event partner. We take immense pride in being the first dental college in West Bengal to achieve the prestigious NAC-A accreditation and the only institute in the state to secure our NIRF ranking in the year 2022. After an inspiring and a stimulating first day, we are excited to continue this academic journey with another day filled with cutting-edge knowledge, engaging discussions, and live demonstrations. We thank you all for your continued participation and enthusiasm, and we look forward to yet another enriching day of learning and collaboration. It is a great honor to welcome our esteemed speaker, Dr. Neeraj Chandrakar sir, a renowned maxillofacial prosthodontist and implantologist with vast experience in advanced implantology and craniofacial prosthetic rehabilitation. Dr. Chandrakar completed his master's in dentistry from RJUHS Bangalore and received specialized training from prestigious institutions, including the NHS in Glasgow, Bromma, Osseointegration Center in Sweden, Belgrade, Serbia, and the University of Kentucky, USA. He currently serves as Associate Professor at Government Dental College, Raipur, and is the Director of Changing Faces, India. He holds multiple national and international fellowships and is actively involved in clinical innovation, education, and research. His numerous accolades include the IMPT Fellow Award, Young Achiever Award by News 18, and the Gaurav of Chhattisgarh Honor. In 2023, he was the only Indian selected as a future leader in prosthodontics at Genova, Italy. We are truly privileged to have you with us, sir, today. Please join me in welcoming Dr. Neeraj Chandrakar sir on stage with a loud round of applause. With that, I would also like to request our principal, sir, Professor Dr. Jayanta Bhattacharya, and Professor Dr. Shomiran Ghosh, sir, to kindly come forward and felicitate our speaker. Thank you so much, sir, for the gracious felicitation. Dr. Chandrakar, sir, now the stage is yours.
Sorry for the technical preparation and very good morning. Before I start, I should say that I always love to come down to Kolkata. The reason behind it is a lovely city. Whenever I came down to Kolkata, I really enjoyed a lot, not just the city, but the culture. And most important thing, I was just talking to the dean. Last time I came to Kolkata, not as a tourist, but rather I came down for shopping. So that is like Kolkata is also known for. So before we go ahead, I'm really thankful to Dean Dr. Bhattacharya, Dr. Ghosh, Dr. Sumiran Das for inviting me over here and giving me an opportunity to speak over here. Indeed, it's an honor to speak in this particular platform. And I can see a lot of young crowd present over here. I hope it's a mixed crowd of both postgraduate student and intern. So before I go ahead, like I just wanted to know like how many of you, apart from staff, I just wanted to know a response from the student side that how many of you have already placed implant so that will give me a tentative orientation to what level I'm supposed to go and go ahead with my explanation. So I want you to just raise your hand. Interns, those who have placed implant. Or those who have assisted also. Interns, those who have placed implant or assisted. Okay. So I think that I should go ahead with the basics and let it be a kind of interactive session. ये तो आ रहा है बराबर. Okay. In Government Dental College, Raipur, and also working as a private practitioner in one of my setups from last almost 16 years from now. And basically my field of, I'm a prosthodontist, so my keen field of work is implantology and maxillofacial prosthesis. And in fact, I'll tell you that I'm a live example where only specialized practice survived. Because many of my students ask, sir, in my private practice, should we go ahead with all practice setup or should we go ahead with specialized? I can say that from almost 16 years from now, I haven't done even a single root canal treatment. And I'm doing only prosthetic work, whether it is a maxillofacial prosthesis, which is my keen inclination, and then implantology, which is my bread and butter. Okay, so coming back to today's topic, today we are going to discuss basics about implantology, how we go ahead in implantology, how to start about implant practice, what are the reasons, and what are the different systems. I can understand that A 2 to 3 hour is a very short duration to discuss about this vast topic, because as a prosthodontist, we know that implantology is like, it takes months together, it takes years together to get that experience. And what I'll try to give you is a overview about basic implant practice. So to start, can you see this image? Don't you see that this image seems to be a soothing in some kind of, like, different age group. And you must have seen a different meme in social media where a single tooth missing can spoil the beautiful face. So that's the importance of a teeth. And I need not of teeth because all of you who are present over here are doctors. But when we discuss about edentulous condition is a big issue. If you talk about the data, in case of partial edentulism, around 40 to 70% of people are in condition of partial edentulism. 40 to 70%. It's a big figure. And this figure ranges from racial region and also differs from country to country. Obviously, if we talk about the figure-wise, the complete edentulous condition is again a very huge problem. WHO has already announced the complete edentulous as a handicap condition. And throughout the world, there are more than 260 millions of people who are in condition of complete edentulism. When we talk about this particular picture in Indian scenario, it's again a big picture. Can you see this? 16.3% of people are in condition of complete edentulism. 16.3% of people, it means अगर आप इससे दूसरे language में बात करेंगे तो almost 21 crore people. 21 crore people, which is, I think, it's more than the population of West Bengal. So imagine how potential is this field. It is having a huge potential just for the complete edentulous condition. And if we talk about a partial edentulous condition, around 40 to 70% of people are in condition of partial edentulism. Why I'm giving this figure? I'm giving this figure to tell you what is the potentiality of this particular branch. What is the potentiality of field of prosthodontics, where we deal about the replacement of missing teeth. Basically, whenever a patient comes down to us, what is their problem? Obviously, they have a limitation. They have a limitation because of their missing teeth. Obviously, this missing teeth can lead to a functional limitation because they are not able to chew, they are not able to masticate properly. They have a limitation of aesthetics. Because of missing teeth, they are not looking good. And overall, it is affecting their socio-psychological status. So what they expect from us? They expect from us this particular point. They expect from us to help them to regain their socio-psychological status by rehabilitating them. They expect us to regain their masticatory efficiency, regain their nutritional status, and overall they want us to help them to regain their quality of life. So we as a prosthodontist have a responsibility to bring back their smile to the normalcy. And how can we do for them? Obviously, what are the different solutions we can provide to them? Let's talk to very basic level. Number one, what is the most common treatment given to the patient? No treatment. Yes? You must have seen a lot of people around you who have a condition of
edentulism, whether it is a complete edentulism or a partial edentulism, and they have not gone for the treatment. There are multiple reasons, whether it is because of patient psychological status, they don't need, they deny any kind of treatment, or because of certain medical condition, or because of certain financial condition. So no treatment can be also a type of treatment. Imagine a clinical condition where the patient is having a very poor oral hygiene condition. Maybe imagine that a patient is having some kind of psychological or mental issue, and if patient is not able to maintain a good oral hygiene, and if you think about giving a prosthesis to such patient, what will be the outcome? You may end up in failure. So no treatment can be also a line of treatment for the patient. A second most common line is a removable prosthesis. I think as a student, this is what you're doing. A removable prosthesis, one of the most acceptable line of treatment. Why most acceptable line of treatment? Especially if we talk about Indian scenario, the finance is important factor. It is most economical, free sasta, and especially if we talk about the institute level, it is done almost free of charge because of academic interest. And not just because of cost factor, but there are certain medical limitations. There are certain anatomical limitations which will lead to only option remaining them is a removable prosthesis, and still holds good. You as a student, you can just assess the importance of this particular line of treatment. आप इसे समझ सकते हो कि as a intern, how many patients you have given any other treatment apart from removable prosthesis. So even though it is an old line of treatment, but still holds good in many conditions. So you need to know about this particular line of treatment also. And then a fixed partial denture. Fixed partial denture, patient comes down to us with one single statement. Sir, I want a replacement of my missing teeth, और मुझे मेरे दांत पहले जैसे थे वैसे ही चाहिए. Immediately what comes to your mind? The only thing comes to your mind is a fixed prosthesis. We are not talking how you are supposed to give a fixed prosthesis, but a fixed prosthesis. And as a student, a fixed tooth supported fixed partial denture is again an important line of treatment. There are certain modification of fixed partial denture, can be a modified resin bond and all, but overall it is a fixed partial denture. And then about the today's presentation is implant supported prosthesis. That's another important line of treatment. It is also a fixed treatment, a fixed partial denture or fixed complete denture with implant supported. So that's another line of treatment. So whenever a patient with partial or a complete edentulous patient come down to you, these are the different treatment options with you. But as a student, you have a kind of dilemma, which one I should opt, which one I should give it to my patient. Let's talk very briefly, because you have already gone through all the advantages, disadvantages, limitation, indication and contraindication. Removal prosthesis. One of the biggest advantage of removal prosthesis is it is comparatively straightforward line of treatment. Most of the time, it does not involve any surgical procedure. Yeah, that's the reason we normally deliver this kind of treatment to the patient. And then another advantage is economical. These are the three major advantages. But obviously, whenever we are giving a removable prosthesis to the patient, the question arises is, are we giving them a substitute, or we are giving them a substitute with limitation? You know the limitation. The biggest limitation is stability. The biggest limitation is retention. कहते हैं ना स्टूडेंट के रूप में कि we are doing border molding, and sir, we are getting one thing and we are not getting one thing. That's, we are not getting retention, but we are getting tension. So retention is another big issue with a removable prosthesis. And obviously, when we give a removable prosthesis, it is we are not rehabilitating the patient. Rather than what we are giving to the patient is a crutch. Crutch matlab baisakhi. So whenever we give a removable prosthesis, even though it is a substitute, it is one of the line of treatment, but it is a line of treatment with certain limitation. And that's a limitation of a removable prosthesis. A next line of treatment is a fixed prosthesis. Obviously, when we give a fixed prosthesis, that is much more acceptable by the patient. But when we give a fixed prosthesis, what is the biggest limitation? We are supposed to do an irreversible preparation to the adjacent tooth. And whenever we are doing an irreversible preparation or iatrogenic damage to the adjacent structure, it compromises its life. Research have already proven that an average life of FPD is around 10 to 12 years. After 10 to 12 years, most of the time we see that the tooth which has been taken as a support or abutment tooth, they give up because of carious lesion or because of periodontal lesion. And imagine if even a single tooth loses its support or single tooth loses its strength, the whole bridge goes for failure. So whenever you are giving a FPD to the patient, you have to assess one important thing is cost to benefit ratio. What are the disadvantages and what are the advantages? You have to communicate that. These 3 slides seems to be very simple, but me as a private practitioner, believe me, these 3 slides are the most important slides when I'm communicating with my patient. If you want to become a good implantologist, what is the most important thing? The most important thing is having mastery in a good sense of articulation. You should be able to communicate to your patient that what you are trying to give and why you are trying to give that particular treatment option. And only when patient is able to understand this particular advantages and disadvantages in very first appointment, they will give you nod for the line of treatment which you have decided for him. And if you're not able to explain your patient these 3 basic slides, कहते हैं ना कि हाथ आया बट मुंह ना लगाया, तो ये दर्द मेरे ख्याल से हर कोई प्राइवेट प्रैक्टिशनर समझता है कि whenever a patient comes down to you for a consultation and they don't turn back just because of your poor communication skill, that hurts a lot. That literally hurts a lot. Even if you are well experienced, well skillful implantologist, and if you are not able to explain to your patient what is the advantages and disadvantages of other line of treatment, there are very high probability you may lose that particular patient. So understand this basic slide as an intern, understand this basic slide as a postgraduate student, that before you start about the concept of implantology, you have to understand this slide just to convince your patient. Now coming to today's topic is about implantology. What is the biggest advantage of implantology? The biggest advantage of implantology is each tooth, which is actually an implant supported prosthesis, work as an entity. वो अपने में अलग है. You need not damage the adjacent tooth. You need not repair the adjacent tooth. And that simple sentence patient understands very well. The advantage of dental implant in comparison to anything else. And that's why you are supposed to learn about implantology. In simple terminology, what is dental implant? Dental implant is a kind of substitute with a fixture or artificial root and crown on top of it. This is normally we explain to the patient कि एक artificial जड़ की मदद से replace करने वाले पद्धति है. इसका सबसे बड़ा advantage हमें आजू बाजू के अच्छे दांत को छूने की जरूरत नहीं है. And this clicks very well to the patient. I'm talking from my experience of last 15 to 16 years as an implantologist. So that's important. When we talk about implantology, again, implantology is not a new concept. Implantology dated back since Mayan civilization, since Egyptian civilization. For intern, it will be interesting to know that it's so old. It's so old, so established line of treatment, and over the ages, there are constant modification on concept, there is a constant modification on design, there is a constant modification on the type of processes which is being provided. Because of time limitation, we are not going to discuss about the different concept which is being given over the period of time. Let us discuss about which is relevant to us in present scenario. But you need to understand that implantology is an age-old process. In present scenario, one of the classification of dental implant are three types: transosteal, endosteal, and periosteal. Transosteal, it is of historical importance, जहाँ पे हम implant place करते हैं through and through penetrating the bone. But most of the time in present scenario, I have hardly not seen even a single case in last 18 years of my experience with a transosteal concept. Just limited or restricted to the textbook, which you need to know. But these two concepts, periosteal implant and endosteal implant, are very much popular in present scenario. When we talk about endosteal, simple thing, and osteal, within bone. An implant which is placed within the confinement of bone. All the designs which you might have studied as a postgraduate student, whether it is a blade form design, whether it is this type of design, whether it is a root form design, all the different design which is surrounded from all the sides with bone are endosteal, placed within bone. Whereas the second type, which is a periosteal, periosteal name itself explains, periosteum, outer layer. So implant which has been placed on the outer layer, anchored or supported by bone screw. That's important. Anchor or supported by bone screw. And the complete implant is placed on the periosteum. Interesting thing, this does not integrate with bone. This does integrate with bone. You must have seen this particular concept every day practice. But how about this? It is interesting that post-COVID, there are higher number of periosteal implants which has been placed. Because post-COVID, what we see, a compromised bone condition. Even pre-COVID, in onco, in trauma cases where there was a limitation of bone, obviously, if we talk about endosteal implant, एक simple सा language. हड्डी है तो implant है, हड्डी नहीं है तो implant नहीं है. When bone is there, you can place implant. If bone is not there, you cannot place implant. Endosteal. But if there is a limitation of bone, you can place periosteal implant. You can place periosteal implant. Obviously, if we talk about skull, somewhere there will be bone. Periosteal implant can be placed over there. There is a quite number of boom in case of mucormycosis related to COVID. But you also need to understand, this is gold standard. Endosteal implant are the best implants, whereas periosteal implant has certain major limitation. Even though there is a good number of documentation in literature saying about the success story of periosteal implant, but when you read in depth, you will understand that periosteal implant is a single entity replacing multiple teeth. And it is covered with soft tissue. Imagine if there is an infection at one point, it will progress and which may end up in failure of complete implant system. And that's the limitation of periosteal implant. But you, as a postgraduate student, you need to understand both, because there are many surgeons, I'm going to say postgraduate students from the Department of Surgery, which you will be preferring to place a periosteal implant. Periosteal implant, commonly called as a patient-specific implant in present scenario. So periosteal implant and endosteal implant are the two common system or design which is being used in present scenario. Then this gentleman, okay. There's a beautiful saying that luck favors hard worker. And he is a live example for the same. We know a concept of osseointegration given by this particular person. And then the complete scenario of implant dentistry changed for a while. Let's see on his own word that what exactly
rabbits could not be removed. The university researcher on a tight budget was crestfallen. His future as a researcher hung in the balance.
At that time, it was a nuisance, a real nuisance, because they were difficult to manufacture, quite expensive, very sophisticated optics, and we couldn't get them out. And when we tried to get them out, we destroyed them. So for a couple of years, we felt that was really a drawback of the system until, because of our collaboration with the clinical colleagues, we understood that this might eventually be more important than the vital microscopic technique that we really aim to develop.
Having both MD and PhD degrees, but no dental certification, this very resourceful man we have come to know as P.I. Brunemark was on the cusp of a discovery that has transformed modern dentistry. He created the first titanium dental implant and coined the term osseointegration to describe the process by which bone tissue fuses it in place. His energy and passionate dedication to science and the welfare of patients was infectious. He had a marvelous sense of humor and a rare compassion for his fellow man. He was also an animated, compelling speaker. Even after the success of his first dental implant, performed on 34-year-old Gösta Larsson in 1965, he encountered tremendous hostility. With a cleft palate, a deformed chin and jaw, and no teeth in his lower jaw, Larsson was resigned to a life of constant pain and discomfort that left him barely able to eat and talk. The operation giving him 4 titanium implants transformed his life and allowed Mr. Larsson to enjoy a long and happy life. It took Dr. Brunemark more than a decade to gain official acceptance of his implant method as a bona fide treatment.
Titanium is a very peculiar material. Depending on the composition of the bulk, which has to be as pure as possible, how the oxide is formed on its surface, which is an inevitable event.
Because of his perseverance, titanium implants have spread well beyond dentistry, and osseointegration is now also used in medical and veterinary applications. In May 1982, Professor Brunemark came to Canada at the invitation of Dr. George Sarb, whose team at the University of Toronto had conducted replication studies. The late Dr. Daniel Sullivan, who attended that first symposium, remarked, "I was stunned by what I was seeing because I could see the impact of it." He had been used to seeing implant success rates of 60% or lower, and Dr. Brunemark was reporting success of 95%. 5 months after the Toronto Symposium, Dr. Sullivan and his oral surgery colleague, Dr. Paul Krogh, placed the first U.S. titanium and osseous implants in Bethesda, Maryland, with PI at their side.
We then put in 4 implants, and that was in '82, and we got the bridge placed, and it is still functioning after 30-some years.
Word of their success spread, and Professor Brunemark had soon established training centers across the United States.
If we try to do what he taught us to do and treat patients the way he wanted us to care for them, we can all feel that he's looking down on us and smiling, and we should probably look up and say, "Tack så mycket," which in Swedish means thank you very much.
My journey as during my training period as a postgraduate student, recently passed out postgraduate student, I had an opportunity to visit exactly same place where the concept of osseointegration was established. And it's not boast up, but I always love to present it because I had an opportunity to meet this gentleman, Professor P.I. Brunnemark, very down to earth, and a very interesting fellow. Only one topic he talks is about osseointegration, irrespective of your age. Imagine this person was talking about a advanced concept of osseointegration to a passed out postgraduate student. That was something interesting for me to know. But what was the zest of this particular presentation for the student? What was the zest of this particular presentation? I hope you heard the word by Dr. Sullivan. He said 38 years of experience of success. That's the most important thing. Can you imagine an implantology which was placed at initial that point of time where the design was kind of crude, and they had a success rate of 38 years? And believe me, the present design, what we have in present scenario, is much more sophisticated and advanced. And if you're following standard protocol, believe me, you'll get a much higher success rate. A much higher success rate. And that always happens with some kind of technical glitch. So that's most important. And since the concept of osseointegration, there is a hell of a lot of modification which is being taken place. After the concept of osseointegration, after the establishment of concept of osseointegration, there is one more important concept which you people should know as a student, is a concept of fibrointegration. Believe me, a concept of fibrointegration, you never want to implement that particular concept, because we know that any implant which is fibrointegrated will end for failure in present scenario. And you don't want any of your implant to be ended up in failure. So, that's fine. We are back to the technical glitch. That's absolutely fine. So with the establishment of concept of osseointegration, there is one more thing which you need to know about the fibrointegration. I have taken this picture from your loving textbook, Nalla Swami, Deepak Nalla Swami. It's a very good textbook. Believe me, zest and condensed. खास तौर पे अगर एग्जाम में पास होना हो तो I'm sorry sir, I'm misguiding student, but yeah, कभी-कभी कुंजी भी काम आती है. So that's about the fibrointegration. And these two concepts, which was given almost at the same time, one was given by Professor P.I. Brunnemark, and second concept was given by, I think, Carl Weiss. I don't exactly remember his name, Carl Weiss. But you need to understand, in osseointegration, there is a direct opposition of implant to the bone. Whereas a fibrointegration, there is a interpositioning connective tissue between implant and the bone. And if there is an interpositioning connective tissue between implant and the bone, it will go for failure for sure. It will go for the failure for sure. Because now with the establishment of concept of osseointegration, we know that for long-term success, there has to be a firm connection between implant and bone. There should not be any interpositioning soft tissue. And those who are periodontists over here or a postgraduate student in a periodontist knows the importance of this particular aspect. If we see a fibrointegration over the period of time, what we should do? As a consultant, pray daily to the God कि हे भगवान ये पेशेंट किसी दूसरे शहर में चला जाए और वापस इस शहर में ना आए. Okay? Or be mentally prepared to bear the same financial loss again, because you cannot charge your patient again and again for the same line of treatment. So back to the basics. When we are talking about a concept of osseointegration, you have to understand this important slide. Why we need to know about a concept of osseointegration? It's simple. If you are dealing with implant practice, the most important thing is you need to know about the osseointegration. How is the physiology? How is the process of osseointegration? But the concept of osseointegration, which you are reading in final year, actually Actually, you got a basic idea in third year pathology classes itself. What is osseointegration? Osseointegration is nothing else but it is a type of healing process. You have already studied healing by primary intention, healing by secondary intention. Whether it is a primary intention or secondary intention, the steps of healing is same. क्या होता है? सबसे पहले डैमेज, चोट लगना, चोट लगने की वजह से वहाँ पे ब्लीडिंग होती है, ब्लीडिंग होने के बाद वहाँ पे हेमोस्टेसिस होता है, हेमोस्टेसिस के बाद वहाँ पे बॉडी के डिफेंस मैकेनिज्म से डिफेंस सेल्स वहाँ पे आते हैं, और एक बार डिफेंस सेल्स फॉरेन बॉडी को खत्म करने के बाद आपके जो रिकंस्ट्रक्टिव सेल्स वहाँ पे आते हैं, and then it is healed again. So 4 steps, which is a common: bleeding, hemostasis, inflammation, proliferation, and remodeling. Very simple. And this is what is concept of osseointegration. Nothing different. So if you see a healing, obviously next chapter which you studied in third year pathology was healing of bone. Healing of bone, if even though the steps were different, but it involves the 4 basic steps. Keeping in mind those 4 basic steps, that is bleeding, hemostasis, inflammation, proliferation, and remodeling. Let's see a beautiful video of concept of osseointegration.
Our bones are a marvel of natural design, continuously rejuvenating through a finely balanced equilibrium of bone resorption and new bone formation. A truly miraculous structure is formed which follows the lines of mechanical load, the trabecular bone. Sometimes, however, the unexpected happens. A drill intrudes and destroys the naturally sculpted bone. Blood vessels are torn and a major defect is created, quickly filling with blood. The titanium implant is inserted where the tooth was previously lost. At first, the only force holding the implant in place is mechanical friction. This is called primary implant stability. Osseointegration, or secondary implant stability, requires a highly complex sequence of additional biodynamic processes. This is facilitated by finely tuned communication between the main actors of wound healing, the cells. The blood immediately perfuses the surgical site, providing the cues for subsequent healing. Within seconds or minutes, ions and serum proteins such as albumin, fibrinogen, and fibronectin begin adhering to the titanium surface. Next, the bleeding is stopped by blood platelets, also known as thrombocytes. When they are exposed to collagen and other proteins from the traumatized tissue and implant surface, they aggregate and close the ruptured blood vessel. Platelets release various messenger substances for cell-to-cell communication, such as thromboxane, which promotes platelet aggregation, or PDGF, platelet-derived growth factor, which stimulates the cell division of fibroblasts. Fibrin monomers spontaneously cross-link, forming a fibrin network. The blood clot permeates the wound space, forming a provisional matrix. It also adheres to the implant surface. This blood clot has tremendous importance as a provisional matrix for subsequent bone healing processes on the implant surface. During the early stages of healing, immune cells clean the wound of the very fine bone chips, tissue debris, and oral bacteria that remain following the surgical procedure. In a first step, bradykinin from the platelets increases blood vessels' permeability. As a result, the endothelial cells move apart very slightly.
On the inside of the vascular walls, endothelial cells promote the attachment of polymorphonuclear leukocytes from the bloodstream. These leukocytes, also known as PMLs, squeeze themselves through the gaps between the endothelial cells. Once they have digested the basal lamina using proteases, they are free to enter the wound. PMLs chemotactically navigate toward the wound along a molecular concentration gradient. These molecules include bacterial proteins, fibrinopeptides, and pro-inflammatory interleukins. Upon arrival, they kill bacteria through the release of reactive oxygen species. PMLs also release highly digestive enzymes such as collagenase and elastase. The wound then proceeds through an uneventful healing process, or a toxic wound environment develops with elevated bacterial counts and toxic byproducts, potentially leading to wound breakdown and implant loss. PMLs can call for auxiliary support, for example, through the release of monocyte chemotactic protein, or MCP1. Macrophages respond and are the next actors to arrive on the scene. They too eliminate bacteria by phagocytosis. Tissue debris is taken up and biochemically degraded. Macrophages synthesize pro-inflammatory cytokines and proteases. Macrophages dominate during the late inflammatory phase. Using endiogenic inhibitors for digesting proteinases, the so-called TIMPs, macrophages help stop the round of tissue destruction started by PMLs. This preserves the matrix proteins and proteoglycans in the wound, which in turn protect important growth factors. Messenger substances such as VEGF, PDGF, and FGF stimulate fibroblasts and angiogenesis, which initiate the proliferative phase. Fibroblasts appear on the third or fourth day. They migrate into the wound using amoeboid movements. They synthesize the protective and stabilizing components of the extracellular matrix, such as collagen, elastin, and proteoglycans. The low oxygen concentration in the tissue affects both macrophages and endothelial cells, stimulating them to create the intracellular transcription factor hypoxia-inducible factor, or HIF. Subsequently formed VEGF, in turn, influences perivascular cells. Perivascular cells are mesenchymal stem cells found on blood vessels. They migrate along the VEGF gradient into areas of low partial oxygen pressure. Here, they form new blood vessels that finally integrate into the existing vascular network. Angiogenesis restores the oxygen supply and forms the foundation of bone healing. Starting around day 7, activated osteoclasts attach themselves to the fracture edges of the residual bone, resorbing it and creating space for bone healing. However, this will initially reduce the primary stability of the implant. Here, the osteoclasts dissolve the bone using hydrochloric acid and proteases, releasing BMP, TGF-beta, and PDGF from the bone matrix, which in turn initiate the formation of new bone. Perivascular cells not only create new blood vessels, they also migrate toward existing trabeculae and to the implant surface, where they differentiate into new osteoblasts under the influence of BMPs from the dissolved bone. The adsorbed proteins, such as fibronectin, have a crucial influence on the attachment of bone progenitor cells to the implant surface. The osteoblasts form an organic matrix that is mineralized by incorporating calcium phosphate. Under the optical microscope, bone is visible on the implant surface. Under the electron microscope, though, a thin protein layer is seen between the bone and the titanium surface. Mechanical stability is ensured by interlocking with the surface of the implant. At the end of the first week after surgery, woven bone is formed at the implant surface. This in turn promotes increasing secondary stabilization of the implant, making up for the progressive loss of primary stability. The formation of woven bone concludes the proliferative phase of wound healing. Orderly and coordinated bone remodeling restores the stability of the site. Load adaptation is of pivotal importance in this context. Initially, woven bone will have grown in the valleys of the implant surface and parallel to it. After remodeling, most bone will be structured perpendicularly to the peaks of the implant threads at right angles to the implant surface. The architecture and organization of this bone becomes trabecular. The structure is thought to be directly responsive to forces imposed through the implant to the interfacial tissues. This is made possible by the synergy of osteoblasts and osteoclasts. The osteoclasts, activated by the osteoblast messenger rankle, resorb the woven bone. The osteoblasts then lay down highly organized lamellar bone. The work of both cells is mainly coordinated by the osteocyte and its own messengers, such as sclerostin. Lamellar bone structures are formed. Similar to the arches and vaults in a Gothic cathedral, they absorb the stresses of occlusal load. We are back at an efficient trabecular bone meshwork, perfectly adapted to the new situation. Osseointegration, a highly complex biodynamic process of cell-to-cell communication, is completed.
So this video is basically a gist of whatever I'm going to speak in further slide. You need to understand this particular video. It's a beautiful video. More you see, more you understand. And believe me, every step is important if you want to become a successful implantologist. This video tells you about how a drilling protocol is important. More damage, more inflammation, more foreign body, there is a delayed process in osseointegration. This also tells us about what is the importance of microscopic level. What are precautions you are supposed to take? Why a sterile environment is important during the process of implant dentistry. And at later point of time, it also told us about the primary stability and secondary stability. What do you mean by primary stability and what do you mean by secondary stability? We'll be discussing in further slide. But a primary stability gives the support, and secondary stability where there is a formation of lamellar bone, which you can correlate with the prosthetic aspect. What I want you people as a postgraduate student is, once I finish my presentation, you please go back to this video again and try to correlate whatever we spoke with this particular video. And then there will be a different perception of implant practice in you. You will start practicing in implant dentistry in different perception. You will take our utmost care even at microscopic level. होता है ना, कभी-कभी हम काम करते हैं और सलाइन बंद हो गया, अरे सलाइन बंद हो गया, चलने दे, इसके आगे हम थोड़ा सा और ड्रिलिंग तो करना ही है. No. Each and everything has certain consequence, and this video will tell you in depth about each and every step which happens at the microscopic level. But coming further to the presentation, this is the most strongest picture in modern implant dentistry. Professor P.I. Brunnermark with Gösta Lorentzen. This photograph was taken in 1990. I hope you remember the first video where we spoke that the first implant was placed in 1965. And almost after 25 years, this picture was taken. So this picture depicts the concept of osseointegration. Gostler, he died in 2006. An interesting thing was, he died because of certain other medical condition. But the interesting thing, we as an implantologist is, he died with all his implant intact. What does it mean? It means a beautiful 40 years of success. आपके पास आपका पेशेंट आके क्या पूछता है आपसे? As an Indian mentality, जो ad आता है ना, mileage कितना मिलेगा, कितना चलेगा? Yeah, that's the common question. We as an Indian, the first thing we ask, अगर मैं इतना पैसा डाल रहा हूँ तो कितना चलेगा? You cannot commit to the patient saying that lifetime. Never ever do that. You can say, with the support of this slide, the first implant which was placed, it went till his life. You're not telling lie. You are telling exactly that thing which is scientifically depicted over there. And I still remember this particular statement which Professor P.I. Brunnermark gave in his last EAO meet, that no one should die with teeth sitting in a glass of water. That's a very important statement. And we, as an implantologist, we are following his golden statement, whatever he gave. And you as a student, you are the future flag bearer. You have to understand the concept, what he gave, keeping an add-on to the modern concept. But base is very important. I hope you remember that your professor must be telling, okay, complete denture banana hai, border molding aise karna hai, primary impression aise lena hai, and maybe some of postgraduate students who are familiar with the digital dentistry, aap ek hi cheez kehte hain, अरे क्या बर्बाद काम है भाई? This is of no use. आज तो डिजिटल डेंटिस्ट्री है, सर को कब पता चलेगा कि डिजिटल डेंटिस्ट्री है? But believe me, जब करंट चला जाता है तो पुराने कॉन्सेप्ट ही काम आते हैं. Brennermark, he gave this concept in 1965, and many a time we still implement his concept even though it's a lengthy process. Why? Because you will encounter many patients who are very much medically compromised and you are supposed to give an implant dentistry to them. Obviously, if a patient is very much compromised, you cannot go ahead with a fast wall technique of immediate loading with the present scenario. You have to follow the golden rules. You have to follow the golden rules which was given by Professor P.I. So let's talk very briefly about the different concept. But before we talk about the different concept, I'm going to say the pathology, it is always better to understand the building blocks, which is normal anatomy. If you understand what is the normal anatomy, then only you can think about pathology. Yes? It's सारे textbook में ये slides हैं. We have studied since first year BDS student, and in fact in present scenario, my daughter who is just 6-year-old, she is studying about the different types of bone. I'm really surprised to see the present education system. So when we talk about the basics, the bone, there are multiple classification, but what is most relevant for you is you need to understand there are two different type of bone, compact bone and calcareous bone. नींद में भी आपसे पूछा जाएगा, तो आप लोग आंख खोल के सारी चीजें बोल दोगे, और मैं आपसे नहीं पूछना चाहता हूं क्योंकि उससे मेरी तौहीन हो जाएगी कि आपको कहीं ज्यादा पता है. Yes? So let's compact bone and calcareous bone. Compact bone, which is having a better lamellar pattern, whereas a calcareous bone does not have that. Obviously, we talk about the Haversian system, and another important thing is, when we talk about the compact bone, the important thing is, its blood supply is limited, even though it is very much systematic, but it's limited. Whereas in spongy bone, there is a more amount of blood proliferation. Simple slide, na? Doesn't, बोले इसमें क्या रखा हुआ है? इसमें ये रखा हुआ है कि whenever you are placing an implant, and if you know the type of bone, you will also understand, okay, compact bone, dense bone, less blood supply. Spongy bone, there are very much chances that there will be an inner blood vessels also, so more blood supply. Compact bone, even though good quality bone, if less blood supply, less chances of osseointegration. More chances of failure. So you as a postgraduate student, you should be more careful with a compact bone rather than a spongy bone. Okay? So let's talk about the different category. This classification was given by Zaab and Lenko, he categorized the bone on the basis of compact bone and calcareous bone present, type 1, type 2, type 3, type 4. D1, D2, D3, D4 classification is also quite similar, which was given by Mesh. And then they also classified the same thing on the basis of position, on the basis of amount of bone which is available. This is like, we as a, I think the postgraduate student, you must be remembering about Atwood's classification given on 1st April 1979. Yes, Atwood classification, pre-extraction, pre-extraction, post-extraction, high well-formed, low well-formed, and so many things. That classification is very important. Why it is important? That is important because the moment you see a radiograph, you will get a tentative idea, and then you will immediately get an orientation that what will be the complication level of your implantology practice for that particular patient. That will be important for you if you are a clinic owner to consult or to communicate with your consultant implantologist. Okay, I got type 1, I got type 2, I got type 4 or E category. Moment your implantologist will think about, okay, E category, difficulty level, high, and higher. Maybe if you see the radiograph, without calling your consultant implantologist, you can communicate with the patient regarding bone augmentation, regarding additional expenses which is involved. So that classification is important for you to understand. I'm not going in much depth about this classification, but this is very, very important about knowing about this particular classification. Another important thing is when you're talking about anatomy is anatomical structure which are approximation with your, or which may have a complication with your implantology practice. This is most important, and believe me, my experience is the difference between an experienced implantologist and a beginner implantologist is this particular slide. They know how to manage the complication. Both of them know how to place implant. But what is more important is they know how to manage complication. And you will be able to manage complication only and only when you know about the anatomy. If you know on the maxillary posterior there is a sinus approximation and you're supposed to place implant, you'll be very much careful. You don't want to violate the maxillary sinus over there. If you know there is an inferior alveolar nerve, you don't want a permanent paresthesia or numbness to the patient. Lingual, anterior lingual region. I asked my student, okay, कौन से region पे implant place करना चाहोगे? Sir, lower anterior, sir. सबसे आसान है. Okay, if you read the literature, in implant dentistry, if your patient can die, it's lower anterior region. Why? Go and read what are the important anatomical structure which are in close approximation. So, it is important for you to understand all this important anatomical structure if you want to become a good implantologist. This slide seems to be simple, but it has a hell lot of clinical implication. People learn over the period of 10 years, 15 years of implant dentistry about the complication. Okay, I've seen this, but there might be a complication during implant practice. And that's the difference between an experienced implantologist and a beginner. And beginner will become a senior or experienced implantologist, but there is a beautiful word which is said. A wise person learns from others' mistakes. And stupid person like me does a hell lot of mistake and learn from his mistake. So you people, as a flag bearer, should learn from your senior's mistake. That's what we are sitting over here. Now, another important slide is, when we are talking about replacing any teeth with an implant-supported prosthesis, even though it looks similar, an implant-supported prosthesis exactly looks like natural tooth, but there is a major difference. It is more kind of biomechanical component. Implant is more kind of biomechanical component, and it does not exactly perform as of natural tooth. in between the bone and implant. And what does this periodontal ligament does? It acts as a shock absorber. It acts as a shock absorber. भाई आपके नेचुरल टूथ में जब आप कुछ चबा रहे हो या फिर बीच में कुछ कंकड़ आ जाता है या फिर बिरयानी खाते वक्त अगर बोन आ जाता है, okay, God has created that way to withstand that amount of load. But implant, if overloaded, may have certain complication over the period of time. And you need to understand that there is a difference between an implant and natural tooth structure. I cannot discuss all those things, but this is very important. Can you see lateral movement and apical movement? A teeth, a natural teeth, since there is a cushioning material in between, it can laterally compress. It can get laterally compressed on shear forces to a range of 50 to 100 micron, 108 to be exact. But implant does not. Implant does not. If you apply too much of lateral forces, it will complicate, it will respond as a bone resorption. Why it is important for you to understand? Imagine clinical scenario, you didn't calculate this, you didn't give a proper prosthesis, maybe a little bit higher prosthesis, which we normally tend to do when we are giving a prosthesis without knowledge. That will lead to overloading, that will lead to failure. Even second condition, even you have done everything perfect, but if patient is a bruxer, undue forces. Natural tooth, to some extent, it can withstand, but implant won't. Implant won't, and that's why you need to understand this particular difference. When we talk about the apical movement, natural tooth, because of periodontal ligament, can get compressed to a range of 25 to 50 micron, whereas whereas the implant cannot, it does not compress to any limit. It gets compressed to 3 to 5 micron only. That is also because of resiliency of bone. A bone gets compressed a bit. That seems to be a simple slide, a simple content. But for most of the people who are non-prosthodontists, I'm not offending any field or any branch, if you don't have this particular knowledge, post-surgical failure is just because of this small line. Why? Because you didn't understood the basic physiology. If you have understood the basic physiology, you would have respected that physiology and given the prosthesis respecting that physiology. And if you don't respect, you may end up in failure, which is called as prosthetic planning failure. We'll discuss about it later. Now, I think most of the students will say, sir, kitna paka ho gaye bhai? बोले बहुत हो गया एनाटॉमी, बहुत हो गया फिजियोलॉजी, पिछले 5 साल से वही पढ़ रहे हैं, काम की चीज बात करो जिसके लिए आप आए हो. Okay, we'll start with that. The question arises is, how and when do we place implant? This is what you came down for. Sir, I joined PG because I want to learn implantology, and I want to learn implantology because I want to learn big. I want to earn big cash. Okay, go slow. There are certain hiccups in between, and you need to understand those hiccups. And then, what are the respective surgical steps, and what are the different options? So we'll discuss each one by one. Let's discuss first about the surgical concept. What are the different surgical concepts? Intentionally, I designed these few slides just for the beginners, mainly for the interns. So you need to understand this is simple terminology, but quite confusing sometimes. Okay? So, simple rule. I cannot cover this itself is a whole big topic. Just a very important thing is you need to understand if you want a long-term success. Like I think many of you who are practicing implantology, you must have heard one particular statement. Initially, implantology was surgical driven. Then it was prosthetic driven. Then it was soft tissue. Tissue is the issue. But now back to the pavilion. Now there is another statement which is quite popular, which is Frost is the boss. Again, Frost is the boss is nothing related to prosthodontists, but prosthetic planning is the most important thing. if you plan your processes, because see, it's simple thing why your patient came down to you. आपका patient आपके पास क्यों आया है? आपका patient आपके पास सिर्फ नकली दांत बनवाने के लिए आया है. He damn don't know about implant. He damn don't know about the component of implant. Only thing he will realize is इसमें इतना पैसा लगने वाला है. So what is the important thing is prosthetic. Everything needs to be a prosthetic driven. And when we are talking about a successful prosthetic driven, we need to understand that there should be 1.5 millimeter of distance between implant, labial cortex, adjacent tooth on mesial and distal, and then palatal or lingual cortex. Simple slide. But believe me, now all the international conferences are directly or indirectly based on this particular slide. Why? Because if you don't respect this particular slide, होता है आमतौर पे मैंने देखा है कि बहुत सारे senior implantologists, moment they will extract canine, okay, canine extracted, big socket, we can go for 4.3 diameter implant, we can go for 5 also, इतना बड़ा तो गड्ढा है. But you are violating that 1.5 millimeter of distance. And if you violate 1.5 millimeter of distance, I think many of practicing implantologists, you must have seen that when your patient come back to you after 5 years, after 10 years, you will see a bone loss on the labial cortex. Why? Because you didn't follow this concept. You have to follow this concept, then only, it is simple slide. हमारे टीचर्स जब हमें बोलते हैं कि ओके इधर 1.5 रहना चाहिए, इधर 1.5 रहना चाहिए, इधर 1.5 रहना चाहिए, ये कुछ वैसा ही है जैसे टीथ अरेंजमेंट करते वक्त आपके टीचर्स आपकी जान खा जाते हैं कि मीजियो पैलेटल कस्प ही टच होना चाहिए, और आप एज अ स्टूडेंट अरे क्या रखा रे भाई मीजियो पैलेटल कस्प पे, 5 बार मेरे को रिपीट करवा दिया. Because he is able to see the holistic picture. He knows about the concept of balanced occlusion, and you don't know about the balanced occlusion as a second year student. And he is giving you in bits and pieces exactly over here. These are bits and pieces which will help you to become a successful implantologist. And then this is again a simple slide. Same thing, 1.5 millimeter, 2 millimeter. I'm not going to discuss. You must have read a lot about it. And since because of time limitation, we are not going to discuss much. The next important thing is that once you know about the basic about implantology, what are the next important thing? One of the most important thing which I'm not going to discuss over here is case history. And why I'm not discussing? Because you people, as a postgraduate student, you have become punters. बोलते ना गुरु बन गए. थर्ड ईयर में भी केस हिस्ट्री लिया, फाइनल ईयर में भी केस हिस्ट्री लिया, इंटर्नशिप में भी केस हिस्ट्री लिया, फर्स्ट ईयर पीजी में भी लिया, सेकंड ईयर पीजी, 5 साल से केस हिस्ट्री ले रहे हैं. So I'm not going to discuss about it. Okay. Jokes apart, case history is a determining factor for long-term success of your implant practice. Imagine you just forgot to take a bruxism history. क्या रात को आप दांत पीसते हैं? होता है, हम भूल जाते हैं केस हिस्ट्री लेते वक्त. आपने केस हिस्ट्री नहीं लिया. And what did you see? You saw a successful implant which has been placed, a beautiful prosthesis which has been delivered, and over the period of time, you become an experienced implantologist and you see all the prosthesis is gone. If it is PM, all the ceramic is stripped off. Where is the mistake? The mistake is just one simple sentence you didn't ask. क्या आप रात को दांत पीसते हैं, खिटखिटाते हैं या घीसते हैं? Yes, you should have asked. I'll tell you one simple, my experience as a student. I take complete detailed medical history. You know why? Because as a third year student, PDS student, I gave anesthesia to my patient, and within fraction of second, patient collapsed. And with grace of God, my teachers were over there, professors in the Department of Oral Surgery were there. Immediately they came and they gave certain medicine, they followed everything, and that was fine. Later, again, जो सारी चीजों में होता है departmental inquiry, आप वहाँ पे खड़े रहते हो. You know what mistake I did? I didn't took a case history from the patient saying that he is hyperthyroid. And you know the thyroxine storm. I gave a LA with adrenaline. Can you imagine? It is a big blunder. So that's why a medical history is very important for you. You need to take. So clinical history, it is very important. Take detailed history of each and every step. And believe me, over the period of time when you become an experienced implantologist, you will start correlating everything. लेकिन अभी आप सिर्फ case history record करते चले जाओ. Next, when we are talking about a case history recording, before you come down to a final diagnosis, another important thing is radiographic evaluation. How will you evaluate a patient radiographically for the placement of implant? As I said, bone है तो implant है, bone नहीं है तो implant नहीं है. And how will you determine that? With the help of radiographic evaluation. The two simplest way is taking an OPG. What does an OPG do? An OPG gives you a beautiful scout view. It will tell you about bone, approximation of all the vital structures along with other things. But we know that OPG has a limitation of accuracy. So second thing which you are supposed to take is IOPA, intraoral periapical radiograph. Intraoral periapical radiograph gives a comparatively more accurate orientation regarding vertical, regarding horizontally on the mesodistal aspect. Yeah, they will tell you कि mesodistally कितना width है. It will tell you occlusoapically or crustoapically कितना height है. But it won't tell you about third dimension, width. And that's why you are supposed to go ahead with CBCT. Many people they ask, sir, हर implant के केस के लिए CBCT लेना जरूरी है? हाँ जरूरी है. It is very important for you to take every case, मतलब हर एक केस के लिए CBCT. Only and only if you have become an experienced implantologist and in certain scenario you try to bypass it. But I use the word experienced implantologist. Otherwise, you people as a beginner, you are supposed to take CBCT for every damn case. Just now I told, आपका patient severe complication में फंस सकता है, lower या mandibular posterior. Can you see this picture? ये हर slide में, हर presentation में अलग-अलग doctors आपको implantologist बताएंगे. If you see IOPA or if you see OPG, you will see, okay, I got a good mesodistal width, I got a good apicocrustal width, height, but you won't be able to see the contour, the lingual concavity. And what we tend to do is, we tend to place a straight implant. When we tend to place a straight implant, you calculated the height 13 millimeter because nerve was somewhere in 15 and 16 millimeter. You decided to place a 13 millimeter, and after 5 to 6 millimeter, there is a profuse bleeding. I think many of the postgraduate students you might have encountered. There is a profuse bleeding. Why there is a profuse bleeding? Bloody bone is, I mean, the canal is 17 millimeter and in 6 millimeter I'm getting a profuse bleeding. Why? Simple. Because you have perforated the lingual cortex. And that's why a CBCT is important. That's why it will help you to determine the width. That's why it will help you to determine all the important vital structure. So you as a beginner have to take CBCT for almost all the cases. Again, time limitation, I'm not going to discuss more about it. Now, very basic for interns and PG students. Component of implant. I have taken this picture from Google, so please don't read what the non-scientific terminology is being used. So when we talk about implants, implant has certain components. The base, what we people call as an implant, is actually a fixture. It is called as fixture. जो जड़ वाला हिस्सा जिसको बोलते हैं ना, bone के अंदर जाता है, that is a fixture. To this fixture, there is a next component which is placed, is called as abutment. Can you see this? This is abutment. The abutment and fixture are connected with the help of abutment screw. Remember the word, there is something called as abutment screw. and there is a similar word which is called as prosthetic screw, which we'll be discussing later. So abutment screw, and on the top of abutment screw comes down your crown, which is natural teeth. So these are the basic component. क्या रखा है? 4 तो कंपोनेंट है, लेकिन जब आप प्रोस्थेटिक डेंटिस्ट्री में पहुंचोगे या प्रोस्थेटिक पार्ट में पहुंचोगे तो हर एक का एक पूरा खानदान है और हर खानदान का हर मेंबर आपकी जान लेने के लिए रेडी रहेगा. सो बट यू नीड टू नो अबाउट द सरनेम, यू नीड टू नो अबाउट द टाइटल नेम, एंड लेटर वी कैन डिस्कस अबाउट ईच. Again, to the basic about the steps of implant placement, starting with extraction. After extraction, the socket will be healed, or in the socket itself, you are placing an implant. You are leaving for certain period of time. Why? Because you saw that video. That video speaks about time duration is recorded, needed for osseointegration. Professor P.I. Brunnermark uses a very beautiful terminology. If you want a healthy baby, it has to be in mother's womb for 9 months. अगर आपको एक अच्छा स्वस्थ बेबी चाहिए तो आपको उसके माँ के गर्भाशय में 9 महीने के लिए रखना पड़ेगा. And that's why he defended his concept. So you need to submerge the implant for a certain period of time, and then you are supposed to go ahead with next step, which is when it is integrated with the bone, place the prosthetic component, and then place the crown on top of it. So these are broad steps of implant dentistry. Now let's discuss one by one. And please stop me in between. अगर आपको किसी को बोर लग रहा होगा और बीच में कोई शायरी वगैरह सुनना होगा तो आप ही सुना देना, मैं बहुत बुरा हूँ उसमें. So next important question is when to place implant. Yes, as a postgraduate student, the most important question comes to us is when to place implant. आपके दिमाग में इसका आंसर क्या आ रहा है? The most common answer is whenever HOD says. Okay, that's a simple rule. कि जब आपके HOD आपको permit करेंगे तभी आप implant place कर पाएंगे. But let's talk in scientific terminology, when to place implant. Obviously, from the time when your teeth is extracted, the implant placement, when you are placing implant, that is being categorized in different named as per from the time of extraction. So first thing is immediate placement. Simple thing. Immediate placement. Extract the tooth, place the implant. Straightforward. Done. Extract the tooth, place the implant. Second is immediate delayed placement. You extracted the tooth, you waited for a certain period of time, and then place the implant. What is the difference? A soft tissue is covered. We'll talk about it later. And then third time is delayed placement. It means you got a edentulous area in which you are placing implant. Very simple slide. Yes? What is there? Immediate, extract tooth, place implant, immediate delayed, wait for certain time, place implant, delayed edentulous area and place the implant. Again, when we talk about the clinical implication, things become difficult. What do you mean by immediate? You, as an implantologist, normally when we talk about an immediate placement, means that's how we convince to the patient. दांत निकालेंगे और implant डाल देंगे. Immediately as a student, अरे वाह, ये तो आसान है. दांत निकाले, implant डाल दिए, advantage. Single sitting में extraction भी हो गया, single sitting में implant placement भी हो गया, एक ही antibiotic coverage में आपका treatment भी हो गया. Yes, quite simple, but not that simple. If you talk about these 3 types of implant placement, the most difficult implant placement is immediate implant placement. I'm talking as a 16-year of practicing implantologist. Still, I do most of my mistakes in this category. Why? Because extraction socket tend to guide your drill. That's the simple rule. That's number 1. And you as a beginner, along with extraction socket tend to guide your drill, there are very high probability that you won't have an orientation regarding the depth, and you may end up in puncturing any vital structure. You may end up in placing implant close to the sinus. If not in the sinus, you may end up placing in damaging the nerve. सर ये ऐसे कैसे हो सकता है? ऐसे इसलिए होता है क्योंकि जब आप ड्रिल से इम्प्लांट ड्रिलिंग ऑस्टियोटोमी कर रहे हो तो every drill has its marking, depth marking, and soft tissue is 2 millimeter above the crystal level, at least 2 millimeter, and you don't get orientation, much better orientation. आप उसे ड्रिल करते चले जाते हो खास तौर पे इस परकेशन को ध्यान रखते हुए. And what you tend to do is you have decided initially that my boss has told me that I'm supposed to place a 11 millimeter implant. And from where you start? You start from here 11 millimeter. Yes, it happens. It really happens. So you as a postgraduate student, I'll strictly say no, no for immediate implant placement. Yes, there are certain cases, certain regions which is considered as quite safe, where there is not much of important vital structure. No beyond mental foramen, no beyond second premolar on maxillary. You may end up in complication. अगर उसके सामने है, okay, that's fine. Try out under the guidance of your mentor. You can think about it. So that's about immediate implant placement. Immediate delayed when. Imagine if a patient has got certain kind of lesion or active infection in that area. Obviously, you don't want to take a chance of infecting your implant. So standard protocol, wait for 6 weeks. 6 हफ्ते के लिए रुको, 1.5 महीने के लिए रुको. Initially antibiotic coverage, and later point of time body immunity will subside the infection which is present over there. That is a better way to place implant. Wait for that. So that's immediate delayed implant placement. And delayed implant placement, most of the time patient come down to us. Advantage of delayed placement, you as a beginner, you will be very precisely able to see that how you are drilling. What is the depth you have gone? Why? Because you are calculating from the crest of bone. Okay, so that's another advantage. And second advantage is flap approximation is very easy. Because you have reflected the same amount, you are approximating in the flap amount. Whereas immediate extraction, imagine second molar, first molar in maxillary, implant placement is difficult, and then approximation of flap itself is a difficult process. So you need to understand the simple slides in relation to clinical orientation. Okay, so that's about it. Then next important surgical concept is loading. What do you mean by loading? Yes, exam ka load और बाकी सारे load. उसके अलावा there is something called as prosthetic loading in implantology. So when we are talking about loading, you need to understand about the loading protocol. Immediate loading. Immediate loading means जिस समय आपने implant place किया, उसी समय आपने processes, partially functional processes दिया. That is called as immediate loading. Second is called as early loading. Usually, immediate loading is considered as from 0 to 48 hours. 0 to 48 hours means within 2 days, if you're giving a type of prosthesis, that comes down to a category of immediate loading. Early loading, 48 hours to 12 weeks. इस बीच आपने prosthesis को load किया. But if you remember that video, osseointegration, I hope you remember there is an osteoid formation, there is a weakening of bone, osteoclast activity over here. Be careful about early loading. Be careful about early loading until and unless you have got a good design of implant. And then the best one is delayed loading. Can you see the color itself? This is not my slide. This is actually I have taken from somewhere. The green. Yes, all the postgraduate student and intern, this is what you're supposed to do. Delayed loading. That is gold standard. Why? If time permits, we'll discuss later. Now, if you have understood about the placement, when you are placing implant, and if you have understood loading, that when you are giving a functional process on the implant, let us talk about the different things. Mix and talk about when you are going to give about it. So first thing is immediate function. What does immediate function means? You place the implant and then on top of it you gave a functional prosthesis. Whenever I'm talking about functional prosthesis, it is a partially functional, okay? So you gave a functional prosthesis. That is immediate function. That is immediate function. Extraction of teeth, implant placement, or implant placement in the heel socket, and you're giving prosthesis on top of it. That's called as immediate function. And then, before we go ahead about the next concept, you need to understand one simple thing. There is something called as cover screw and there is something called as healing abutment. What is the difference between it? Cover screw prevents any kind of tissue growth within the thread part of implant or hex part of implant or conical connection inside the implant where screw is going to engage. Cover screw, it covers the screw part. Simple. And second is healing abutment. Healing abutment, it assists in healing. What is the major advantage, this difference? This is basically meant for submerging the implant. If you are planning to submerge the implant, leaving it undisturbed, you are supposed to place a cover screw. If you are not planning to submerge the implant, you are supposed to place a healing abutment. Okay? Or if you are planning to expose the fixture to external environment, it is healing abutment. Okay? So I hope you have understood the difference between healing abutment and a cover screw. Sorry. Now, coming to the next slide, which is early loading. So early loading, we have already discussed early loading beforehand, 48 hours to 12. If we have discussed about the duration, you need to understand early loading can be of two types. It can be one-step early loading. It can be a two-step early loading. One-stage early loading, if it is one stage means you, at the time of implant placement, you are giving a healing abutment. If you are giving a healing abutment, it means there is no need of second stage surgery at any point of time when you are giving prosthesis. Is it clear, all of you? There is no need of second stage surgery, I'm just reflecting flap, at any point of time. But if you have placed a cover screw, even if you are doing a early loading, you know very well soft tissue जो है 2 दिन 3 दिन में कवर होना चालू हो जाता है. आपको 2 दिन 3 दिन बाद भी इसको रिफ्लेक्ट करना पड़ेगा. So it becomes a two-stage procedure. You have to give anesthesia twice. Okay? You will understand this slight correlation when we will be talking about immediate loading. But did you understood early loading can be one stage, early loading can be two stage. Same thing, a delayed loading. Delayed loading can be one stage, a delayed loading can be two stage. So if you have got an orientation about this permutation and combination, let's talk about next important concept, which is about the loading protocol. Okay? Which is about the loading protocol. It is basic. It is important for you to understand the loading protocol. Starting from the very first protocol which was given by Professor P.I. Brennama to a modern day concept of immediate loading. Okay? So first concept was given by Professor P.I. Brennama, and he said that you need to leave at least 6 months after extraction of tooth, then place implant, and then wait for period of osseointegration depending on the bone, but that is minimum 4 months. Is it clear? If we talk about time duration, it is very lengthy time duration. पहले दांत एक्सट्रैक्ट किया, 6 महीने वेट किया, 3 से 6 महीने वेट किया, फिर इम्प्लांट प्लेस किया, उसके बाद ऑस्टियो इंटीग्रेशन के लिए वेट किया. That's why he called 9 months as a to keep for 9 months. So this is Brennemark's protocol. Why he said that? He said that because if there is a periodontal infection over there, there are chances that your implant may go for failure. And if you have seen that video at least for long period or long duration. And if you hurry over here, there are chances you may end up in failure. So always in implant dentistry, you should be in commanding terms. I'll tell you one golden statement, not from this. My professor taught me one thing, and apart from all learning, I learned the most important thing was learn to say no to the patient. That's the most important thing. Yeah, I can understand that if we are talking about a full mouth rehabilitation, that patient gives somewhere around 5 lakhs to 8 lakh rupees for a full, both the full arch. It's a big money, alluring for any implantologist. But you should learn to say no if you feel that you are not capable enough. If you learn to say no, if you feel that in future there could be a medical complication or there is a medical complication limitation. And if you start learning this, स्टार्टिंग में दिमाग में आता है इतने बड़े पैसे को मैं कैसे मना कर सकता हूँ. अरे दिल में पत्थर रखो और मना कर दो, आएगा बाद में पेशेंट आएगा. Okay, so that's about a loading protocol, which was given by Professor P.I. Brennemark, and then next concept was given by Professor Misch. Professor Misch in 1980. He gave a concept of something called as progressive loading. Professor P.I. gave a Brennemark protocol and progressive loading. So what is progressive loading? He told, submerge the implant. Submerge the implant, wait for the period of osseointegration, and then the difference between Brennemark protocol and Misch protocol, apart from 6 month waiting period, is when you are giving a prosthesis, go in a gradual manner of loading. And that's very important. Believe me, till 2019, I have done more than 65 full mouth cases. And with God's grace, not even a single full mouth got failed. Only reason was progressive loading. I still follow progressive loading if my patient is within Chhattisgarh. But obviously, if patient is coming down from far, or those patients who want an immediate prosthesis, yeah, immediate prosthesis or immediate protocol. We'll be discussing about immediate protocol later. But progressive loading still gold standard. It is very important. You need to understand. So gradually load it. If time permits, we'll discuss about gradual loading. So basically, you need to understand the progressive loading complete concept is based on Wolff's law. Wait for remodeling. Once the bone has remodeled, you need to understand the bone can respond in two ways, either on the left side or on the right side. Interesting figure, it says that 60%, you know very well that wait for 3 months in case of mandible, wait for 6 months in case of maxilla. This is what our senior has told. But if you talk about bone to implant contact, only 60% bone to implant contact is being seen till 6 months. Till 3 months or 4 months. And then over the period of time, there is a further enhancement of bone contact. And that further enhancement of bone contact is Wolff's law. Very, very complicated. As a postgraduate student, I always used to say, kya hai bhai, Wolff's law. But believe me, when you start clinically implementing it, you will understand this concept. Now, when we are talking about a progressive loading, what does a progressive loading means and how you are supposed to give a progressive loading? Progressive loading, naam se pata chal raha hai, gradually load karo. So gradually load karo in the sense, there are different ways with which you can load it gradually. First is time, but obviously when we are talking about time, depending on the type of bone. This statement you know very well as a student or as a practicing implantologist. Mandible, 3 months. Maxilla, 4 months. Why 3 months? Why 4 months? Why not same? It's simple. Because of type of bone. Normally in mandible we see D1, D2, D3, D4. That's normally what we see. So obviously there is a difference on type of bone. And that's why we wait for different period of time for osseointegration. 3 months for mandible is sufficient because there is already initial good amount of bone to implant contact. Maxilla, since it is having a less density, it takes little little bit more time to have a minimum amount of bone to implant contact. Then next important factor is occlusal material. So how progressive loading plays an important role in occlusal material? Initially, do not give any contact. How you cannot give any contact? Submerge it. If you are not submerging, place a healing abutment which is out of contact. So that's no contact. That's the first phase where the osteoid matrix is formed. And then start with something more softer material which acts as a shock absorber like acrylic. Once you have given acrylic prosthesis, then only, this is after 3 to 4 months, acrylic prosthesis. Why? Because after 3 to 4 months, only 60% bone to implant contact is there. After 3 to 4 months, you recall the patient, and give him a definitive prosthesis, whether it is a zirconia or whether it is a PFM. Why? Because zirconia and PFM are more rigid material. They are not meant to be a shock absorber. So, if you remember the Wolff's Law slide, it can go on this side after 3 months. After 3 months, if you give the hard material, there are chances it can go on the downside. So that is what a progressive loading concept speaks about. And when we talk about a diet, especially when we give a full mouth rehabilitation to the patient with immediate loading or even with delayed loading also, first thing is what? We ask patient, अगर मैं immediate loading भी कर रहा हूँ patient को, तो मैं ये बोलता हूँ ये सब दिखाने के लिए है. इससे आपको कुछ भी नहीं खाना है. जो कुछ भी खाना है वो गुटकना है. खिचड़ी, दलिया, दाल चावल. Just swallow it. Do not try to masticate it because this is basically meant for aesthetic purpose. If you try to masticate it, I'm not responsible for its failure. And patient follows that. Okay? So that's, when you're talking about a diet, especially in relation to progressive loading, give a soft diet, which causes a very nominal amount of occlusal forces. Then gradually increase it. After 3 to 4 months, call your patient. Give him a temporary prosthesis, which is a fixed temporary prosthesis made with acrylic. Maybe supported with bar, but acrylic, why? Because it has certain amount of shock absorption. The force is comparatively less. And then after a certain period of time, give him a definitive prosthesis. In fact, the modern day concept, like I think all the surgeon and prosthodontists, their dreams. Now, next most important thing is, in 1993, Glib on his work, he said, even though Brennemark told that you're supposed to wait for 6 months before you place an implant after extraction, in his research work, he found 98% of success rate. And that was the turning point for immediate implant placement. Extract the tooth, clean the socket, debride the granulation tissue, make the area as sterile as possible, and place the implant. So that's how the concept of immediate implant placement, I'm not talking about immediate loading, that's how the concept of immediate implant placement started by Grip. And then next concept was immediate loading, which is like present day, very popularly being practiced is immediate loading. Immediate loading, place the implant, whether you are placing an extraction socket or complete edentulous area, you place the implant and then give the prosthesis. So that's our next concept, which is immediate loading. And immediate loading is basically dependent on 2 factors, which is primary stability and secondary stability. What it is, we'll discuss in a couple of minutes. And then, sir, let me know when to stop because, especially from government institute, I keep on blabbering. But I know that 45 मिनट के बाद ओवरफ्लो होना चालू हो जाता है और हम इम्प्लांटोलॉजी से वो बड़ा बाजार या फिर किसी और एरिया में घूमना चालू कर देते हैं. So if you feel saturated, maybe some of you can crack some good joke. I don't mind on me also. So we'll take a break whenever you feel like. But we'll continue till Sir's order. coming to the immediate loading. When we talk about immediate loading, it is basically dependent on one critical factor, which is implant design. Remember one thing, implant design, surgical protocol, and prosthesis. These are the three key factors which will determine your immediate loading. Because nowadays, most of the student who comes on to me, they say, sir, delayed में कौन patient भाग जाता है, immediate के बारे में बताइए. तो immediate के बारे में जानने के लिए ज़रूरी है. You need to understand this. You need to understand this particular thing is immediate loading and implant stability. Simple terminology, लेकिन वो क्या बोलते हैं कि भानुमति का पिटारा. Means there is a huge amount of thing which is inside it which you need to understand. Is primary stability. Primary stability means when you place implant, it is something like दीवार में कीला ठोकना. Not to offend bicortical implant, they completely dependent on. They say one statement. 1 मिनट लगता है मेरे को implant डालने में. किसी को भी 1 मिनट लगेगा दीवार में कीला ठोकने में. But when you are dealing with a vital structure, you need to assess, you need to go very carefully and gently. So that's why you need to understand a primary stability. It is basically because of design of implant which gives you a primary stability. And then there is something called as secondary stability. The primary stability is a mechanical stability. कि आपने दीवार में खील ठोका, क्या खील और दीवार में कोई किसी तरह का केमिकल या बायोलॉजिकल बॉन्डिंग रहता है? नहीं रहता. इट इज प्योर मैकेनिकल. वो फ्रिक्शन से वहां पे अटका रहता है. सेम थिंग प्राइमरी स्टेबिलिटी इज ऑल अबाउट. फ्रिक्शन से mechanically it is retained over there. Whereas secondary stability is, remember that video, where there is a gradual formation of bone to implant contact. Primary stability, is it there was no contact? Yes, it was there, but it was not biological. And over the period of time, this biological slowly shifted to, this mechanical slowly shifted to biological. And that's how you get a secondary stability. Very briefly about stability. When we talk about a stability, there are three important things which is dependent on stability. One is local bone quality and quantity. Second is implant geometry and design. And third is surgical procedure. We'll be discussing very briefly because basic implantology is in gist of these three contents. We have already discussed about bone quality and geometry. Bone quality in the sense, you know very well, D1, D2, D3, D4. D1 more of cortical, D2 comparatively less, D3 and D4 is more of trabecular or spongy bone. It's simple. If आप इन दो दीवार को देखिए, एक में जो मैश पैटर्न लगा हुआ है और एक जो सॉलिड है, अगर आप सॉलिड में खील ठोकेंगे वो ज्यादा स्टेबल रहेगा कि मैश पैटर्न वाला ज्यादा स्टेबल रहेगा? ऑब्वियसली सॉलिड वाला. So if you are placing an implant in a dense cortical bone, there are more bone to implant mechanical contact that will give you more primary stability. Whereas if you place an implant in spongy bone, which is having more of trabecular pattern, there is less chances of primary stability because of type of bone. That's why primary stability, अगर आप किसी केस को immediate loading के बारे में सोच रहे हो, NT D1, D2, maybe D3, not D4. D4 is never meant for immediate loading until and unless you are joining multiple implants together and acting as a single unit. So that's on the basis of bone quality. Next important thing is about implant geometry. This is very important for postgraduate student and why? Because many a times we tend to get influenced from the manufacturer side, their representative. वो आके ये बोलता है कि ये सबसे बढ़िया है, मेरे में नमक है, मेरे में हल्दी है, and all those things. Do not fall on their trap. You use your common sense, you use your logic, you use the literature which has been documented sufficiently, and then only select the particular company. There is a huge range of different companies. I think in market there are almost, in present scenario, 54 plus implant companies which are available. But there is a strong logical reason why you should opt for a particular on the basis of some representative told, not on the basis of some representative told or some of my senior told. So that's what even you people are supposed to select. Select an implant company which is favorable and suitable, which designs are basically meant to give a good primary stability. Again, a design of implant is a huge topic. I'm not going to discuss about it. So you need to understand that our implant surface can be modified. Along with macro design, you also need to see microscopic level, whether it is a machine surface, whether it is a macro surface, or whether it is nano surface. Simple thing. If you switch from machine surface to nano surface, there is an increase of surface area. और इम्प्लांट डेंटिस्ट्री का एक सिंपल सा कॉन्सेप्ट है कि जितना बड़ा इम्प्लांट उतना ज़्यादा बोन टू इम्प्लांट कॉन्टैक्ट. But we know simple thing, I have a limited amount of bone over there at a particular site. If I have a limited amount of bone, a height of imagine 15 millimeter or height of imagine 10 millimeter and width of 5 millimeter, then I have my bone limitation. I cannot change the bone unless I go ahead with the bone grafting, which is the most easiest thing. I should opt for an implant which provides me a more surface area. And that's why there are different area-wise modification. If you see, can you see this slide? This slide will tell you if this is a machine surface. Whereas if you see a macro scale surface, there is a further increase of surface area because of modification. Whereas the bottom one is the nano surface. So it's like if you have taken this implant, macro implant, which is a machine size, same implant of nano surface is actually this big. Why? Because it is crumbled to this size by surface modification. And that's the importance of opting for an implant which is having a better surface area, which is having a nano surface area. And there is a sufficient amount of literature and research. Let's see why I opted for Alpha Bio.
plant geometry and design. Again, because of time limitation, this is very big topic. I'm not going to cover over here. Coming directly to another important thing which most of the students are interested is about the surgical procedure. Sir, how a surgical procedure is going to affect my stability, whether it's a primary stability or secondary stability? It is critical. It is important. Why? Because I've seen many of my colleagues itself who are practicing from almost 10 years and more, and they have got one kit from the starting till last, और कभी-कभी बोलते हैं कि ये जीवन के साथ भी और जीवन के बाद भी. Okay. So there is a reason why you're supposed to change those drills. There is a reason why there is a particular design of drill. And if you want a good success rate over the period of time, you need to have an understanding about the drill bits also. So when we talk about the drill bits, you need to understand the first thing which is about osteotomy location. Osteotomy location in the sense when drilling protocol, if it is a compact bone and spongy bone. You know very well if it is a compact bone, there is a less of blood supply, less vascularity over there. If there is a less vascularity, then obviously there are chances of failure of osseointegration. So you need to be careful about the compact bone. Whereas spongy bone, if not D4, there is a good amount of blood supply which gives a higher success rate. So osteotomy does matter over there. Another important thing is your drilling protocol changes. If you have got a compact bone, to place an implant, you have to, say for example, if you are placing an implant of diameter 4.3, then in that case, you are supposed to do a sequential osteotomy till 4.3. Because compact bone does not provide any kind of room during placement. Whereas if it is spongy bone, a D2 type of bone, you are supposed to go ahead with one size less. If it is 4.3 size implant you are supposed to place, or 4.2 size of implant you want to place, go ahead with a sequential drilling of drill size 3.8. Whereas if it is D4 type of bone, maxillary posterior region, old age female with osteoporosis, then even a single initial 2 mm drill also is fine. It's all about how much primary stability you are getting. Okay, so depending on the type of bone, your drilling protocol completely changes. Go with a manufacturer's instruction, read the literature properly, and then only go ahead with sequential drilling. Because many of my colleagues who are practicing implantologists, their single complaint is, "Sir, stability aata hi nahi." Stability isliye nahi aata because you don't know about different type of bone and different drilling protocol. Or different drilling, whether it is if it is a D1 type, there's a different drilling protocol. D2 and D3, there is a different drilling protocol. D4, there's a different drilling protocol. And you have to have a basic understanding about that protocol. Next important thing is irrigation. We have seen at microscopic level, there is a lot of vital micro cells which are involved, which lead to the successful outcome. And we know very well, anything which cuts down, there is a heat generation. And if there is a heat generation more than 47 degrees, obviously there will be necrosis. So rather than getting osseointegration, you may end up in failure if there is an excess heat generation. And what is the simplest way to reduce the heat generation? One of the simplest ways, using an external irrigation. Obviously we use a saline, and many of us use a cold saline because it acts as both hemostasis as well as reducing the temperature. So you use a saline to reduce the heat generation. There are two different types of irrigation: external irrigation, internal irrigation. External irrigation, most probably, if you see that in surgical handpiece, from outside directly irrigation is being projected, like exactly similar to your aerotor. एरोटर में होता है ना कि आप ट्रिम कर रहे हो और बाहर से एक वाटर का स्प्रे जा रहा है लगातार. So that is external irrigation. When we talk about internal irrigation, there are a few drills which has a central canal on it. And then there are two-way irrigation pipe. One pipe
goes to external irrigation, and second pipe goes exactly at the central of drill bit. So that is for internal irrigation. And if you want a successful outcome for D1 type of bone, obviously D1 bone is very dense bone. If it is a very dense bone, there are very high chances of more and more heat generation. More heat generation beyond 47 degrees centigrade, failure. And that's why if you see many of the postgraduate students, they end up of implant failure, especially in the mandibular anterior region. Why? Because they have applied excess force which lead to the excess heat generation. But there was a limited amount of coolant. So internal irrigation plays very role. There are few companies which provides a drill bit with internal irrigation, but if you follow a good external irrigation protocol, that is more than sufficient. Then number of blades. If there is a more number of blades, there is a reduced efficiency of chopping. Exactly the same thing what we have studied in conservative. Burrs, more number of fluids, okay, rake angle and all those things. Same thing holds good over here. More the number of blade, there is a reduced number of chopping efficiency after a certain limit. Then there is something called as drill design and drill fatigue. When we are talking about drill design, it is very important for you to understand. In present scenario, there are two broad categories of drills. One is a standard drill, and second is called as step drills. Before that, there was one more category. Now it is kind of obsolete. There is something called as parallel drill bit, and there is something called as tapering drill bit. Parallel drill bits are basically meant for parallel implants, whereas tapering drill bits are almost for most of the root form implants. In tapering drill bits, there are two types, standard and step drills. That is very important because till certain age, I was not knowing the difference between this standard drill and where to use and how to use. So that's a drill design. And then next most important thing is about drill fatigue. If you apply too much pressure, there will be a drill fatigue. आप बिल्कुल नया जैसे अगर आप में से सबने पीजो रिमर यूज किया होगा पोस्ट एंड कोर के लिए, you must have realized if you apply too much of pressure for post preparation, there is early worn off of the sharp edges. Same thing holds good in drill also. If you apply too much pressure, there will be early worn off of the sharp edges. It has been said approximately 2 kg. Approximately 2 kg of force needs to be applied. Especially be careful in the compact bone. Do not apply too much force. If there is too much resistance, take it out, drill it, take it out, drill it, and use a sequential drilling protocol. That's the solution. So drill fatigue needs to be careful. And again, it is said that keep changing your drill. What company says 20 to 25 osteotomy? बट अगर इंडियन सिनारियो में हम 20 to 25 ऑस्टियोटॉमी में चेंज करना चालू कर देंगे तो हमें पेशेंट को और एडिशनल चार्ज करना पड़ेगा. सो दैट्स प्योरली अप टू योर जुडिशियस थिंकिंग. डू नॉट डू द वे व्हाट यू डू, लाइक आई एम टॉकिंग टू द पोस्ट ग्रेजुएट स्टूडेंट. वैसा नहीं करना जो एक एरेटर ले लिया हमने फर्स्ट ईयर एमडीएस में, फाइनल ईयर एमडीएस में भी वही बार चल रहा है, उसके बाद फर्स्ट ईयर ऑफ प्रैक्टिस लाइफ में भी वही चल रहा है, सेकेंड ईयर में भी वही चल रहा है, और धीरे से जब एरोटर खराब होता है तब ख्याल आता है कि हमारा, तब हम ये बोलते हैं कि एरोटर घटिया कंपनी का था. ओके, सो बी केयरफुल. If believe me, keep changing your drill bits, specifically few particular drill bits, like initial जो हम 2 mm वाला जो यूज करते हैं उसको चेंज कर लो, क्योंकि आमतौर पर वो सबसे easily worn off होते रहता है. And it costs 2,000, 2,500 rupees only for that. So every year keep on changing 1 or 2 which you feel that is worn off. So that's your personal judgment. Do not use one-off drill bits, because if you use a one-off drill bits, there will be excessive heat generation which may lead to surgical complication. Drill speed during osteotomy, that's very important, because again, as a postgraduate student, normally we don't know, sir, there is a sequential drilling, and what speed we are supposed to use. Obviously, if you use a higher speed, there are excess heat generation. And that's why you are supposed to use a reduction gear handpiece. The basic purpose of using a reduction gear handpiece is you will be able to have a same chopping efficiency at lower speed. कम स्पीड में आप ही तरीके से उसको चॉप कर पा रहे हैं. क्यों? क्योंकि आपका जो रिडक्शन गियर हैंडपीस से फॉर एग्जांपल 1:4, 1:4 का मतलब ये है कि इफ यू आर अप्लाइंग 1 न्यूटन, that 1 Newton, because with the help of gear, it is being multiplied at 4 Newtons. So that's the importance of reduction gear handpiece, and the importance of reduction gear handpiece is it helps you to chop the bone efficiently even at lower speed. कभी ये ट्राई नहीं करना, लेकिन अगर कभी धोखे से आपने माइक्रोमोटर यूज किया धोखे से, जो कि स्ट्रिक्टली नॉन एथिकल है, तो यू विल सी कि इनिशियल ऑस्टियोटोमी के वक्त ही वो रुक जाता है, बिकॉज इट डज नॉट हैव दैट चॉपिंग एफिशिएंसी. और हाई स्पीड में करोगे तो देयर विल बी अ गुड अमाउंट ऑफ बोन नेक्रोसिस. यू विल फील द बोन बर्निंग ओवर देयर. So that's the importance of drill speed. Again, initial drill, anything less than 2000 RPM. Anything less than 2000 RPM is shown to reduce the heat generation. Only thing you need to remember is if you are using bone tap, okay? If you are using, there is something called as bone tap, I'll show you. If you are using a bone tap, you need to reduce the speed to 25 RPM or 100 to 25 RPM. And obviously, if we are placing implant, it has to be at 5 to 10 RPM, not more than that. Because कभी-कभी मेरे साथ भी हुआ है कि कभी-कभी I forgot to change the programming, and at 800 RPM, zoop. Do not do that. Why? Because your implant surface is a modified surface. There is a coating on top of it. If you place implant at higher speed, apart from other disadvantage, you are going to spoil the external surface. Then the complete concept of modified surface is gone. और बाकी जो disadvantages हैं वो है ही हैं. So you are supposed to place implant at lower speed of 5 to 10 RPM. Again, it's a huge topic, so I'm not going to discuss much of it. Just remember this thing. This slide is important as a postgraduate student. This line is important. Drilling procedure should be intermittent. What do you mean by intermittent? Intermittent means 5 सेकंड के लिए ऑस्टियोटोमी, 10 सेकंड के लिए ब्रेक. एक experienced implantologist इस चीज को जानता है, and he knows that by default he is practicing that. How much time an osteotomy, sequential osteotomy takes? Hardly 3 seconds, 4 seconds, 5 seconds. And then when you change the birth from one to a gradually larger size, you give a break of 10 seconds. That happens by default. But for beginner, you need to be careful that if there is a too much of resistance, do not keep on forcing it. If you keep on forcing it, it means you are causing excess heat generation. And excess heat generation means bone temperature raises above 47 degrees centigrade. There could be a necrosis. So intermittent osteotomy is another way which will help you to reduce heat generation. I'll just skip the rest of the points. Yeah. So coming to this important step, again, I told you that there are two different types of drills. One is for the parallel drilling, and another is for the tapered one. Most of the implants which are available in present scenario are tapered implants. So we need not worry about parallel implant. But there are a few implant systems which is based on the parallel implant system, and the osteotomy is dependent on it. What is more important for you is this particular slide. It is being shown in research. If you use a tapered drill bit for tapered osteotomy, you get a better primary stability. So that's another important thing. Again, I'm not going to discuss in much detail about it. Coming to the step-by-step for postgraduate students, that's step-by-step how you're supposed to go ahead with osteotomy. First is puncture to the crust. You can use a Lenderman drill, you can use a round burr, you can use anything. That is again optional, but it is always better to puncture the crust with any kind of precision drills or sharp drills. Once you have a puncture, my experience, I'll say always use a smaller size Lenderman drill,
Because if you use a larger size, normally it does not have markings on it. And you tend to do a over osteotomy, there are chances you may damage the vital structure. Basically, this precision drill is for what purpose? Only for one purpose, is to puncture the cortex. If you have punctured the cortex, its purpose is done. Then go ahead with the sequential osteotomy with 2 mm, 2.8 mm, 3.2 mm, 3.6 mm, 3.8 mm, 4.1, depending on what size of implant you are planning to place. So that goes ahead with sequential osteotomy, and I have already told you about the speed. That RPM, how much you are, anything less than 2000. Anything less than 2000 is more than sufficient. I personally prefer to keep somewhere around 1200. My mentor prefer to keep around 800 because the advisable range is somewhere 800 to 1200. So it's over the period of time you will start realizing at what speed you are supposed to give. But research have proven that anything less than 2000 reduces heat generation. Yeah. Another important thing is that once you have done a twist drill of 2 mm, the next important step is cross-check, whether you are going in right direction or not. That is very, very important. To cross-check, there is something called as direction indicator pins. And interesting thing is, many of us don't know that both sides of direction indicator pins are meant for certain purpose. The longer side is for initial punch when you are given, place it inside, take a check radiograph. Always, always, always take a check radiograph at the surgical site, cross-verify that you are exactly on your planned pathway. If it is, go ahead with increasing the diameter. If not, change it as per need. Okay, twist drill. And then after initial twist drill, it is always better to go ahead with cross-check with a depth probe. Cross-check with a depth probe that whatever you plan depth, it is there or not. That's a very common complication which a beginner does is. They don't check with the depth probe. They keep on doing osteotomy. Say, for example, if you have planned to place an implant of length 11.5 millimeter, you keep on doing 11.5 millimeter, keep on doing 11.5 millimeter, and not cross-checking it. And when you place an implant, it is slightly supracrustal. So be careful. Cross-check it with depth probe. That will give you exact orientation that what is the minimum, whether the desired amount of osteotomy is done or not. And then this is something called as cortical drill. Again, the cortical drill and tap screw. These two, cortical drill and tap screw. It is needed only in D1 type of bone. I think many of you have placed the implant in lower anterior, and what you see is when you place it last 2 to 3 millimeter, super stable. You keep on tightening, giving a higher torque. There are two consequences. There is something called as pressure necrosis, or there is something called as platform rupture. ये दो में से कोई एक चीज होगा. ऐसा इसलिए because you didn't use the tap screw. And if you see this, the beauty of this is this cortical drill is partial depth. So what it does is it expands only the top part. See, imagine I'll tell you one clinical condition. You plan to place a 3.75 implant in mandibular anterior region. You did a osteotomy till 3.6 millimeter as per the guide. Later what you realize is the top 3 millimeter, you are not able to place the top 3 millimeter because the only you find resistance on the top part. क्योंकि नीचे तो already osteotomy desired height तक हो चुकी है. That's because you didn't use the cortical drill. You are supposed to use the cortical drill, and then only you will reduce the chance of pressure necrosis. Then once you have done a desired osteotomy, to carry the implant and to place the implant, there are 3 ways. One, you can use a motor driven. Second, you can go ahead with the ratchet driven. And immediate loading, you're supposed to check the primary stability. There are two ways to check primary stability. Either you use a ISQ, implant quotient, or you're supposed to use the ratchet. Normally, ratchet is not advisable. If you are using a ratchet, see to that you are not loading or giving torque anything beyond 35 Newton centimeter. Why? Because beyond anything, उससे जो भी ऊपर है, वो आपके primary loading criteria से ऊपर ही है. Why you want to keep on cross checking? Why? Because you will realize that even the experienced implantologist will say, the moment you keep on trying, you try till 55, and exactly at 56 the complete stability is gone. Then delayed loading. So torque ratchet is not indicated. Again, let's see Alpha Bio. Alpha Bio has got a good kit which is called as all-in-one kit. Then narrow diameter conical connection. So all the three systems are available. So that's our drilling protocol for Alpha Bio. What I told you, the desired diameter, and I told you that there are two different types of drill. One is called a standard drill, and one is called a step drill. It is always better to keep our head. This is optional, but you should have the step drill in your armamentarium. The reason behind this is because the step drill, the bottom part is slightly of narrower diameter, and most of the area where you place the plant, the bottom is what? It is cellular bone. It is spongy bone. It has certain amount of resiliency. So the external area, if it is expanded, it will keep a good primary stability. Why? Because the effect is one size per. So if you are planning for immediate loading, no. Yes, please. Let's see a drilling sequence. So that was the drilling protocol for a standard drill. Now, when we are talking about a step drill, there's a difference of drilling protocol for standard drill and step drill. Let's see another video which depicts about the difference between a standard drill and a
key thing is, irrespective of whatever type of technique you are using to place your implant, just remember one thing, there should not be overloading. Research have already proven that anything, there is a recent literature, anything till 80 Newton, it's absolutely fine. Okay? 80 Newton it's absolutely, but beyond that, there are certain conditions जहाँ पे आप 80 Newton के beyond भी टॉर्क देने की कोशिश करते हो, उसको infinity में डाल के टॉर्क, do not do that. That will 100% lead to a pressure necrosis. And how will you judge? After 3 months. After 3 months, from the implant, you will see about a 1 millimeter of bone loss. And why that 1 millimeter of bone loss is? Last में आपने सोचा कि नहीं अब तो उसको वापस निकालूंगा ही नहीं, वो अंदर जाके ही रहेगा. Don't do that. Simple technique is, if you find too much of resistance, set your ratchet at 45 Newton, set your motor driven at 25 Newton, and if you find there is a more resistance, use a tap or use a next size drill only for the crystal. Crystal में maybe half the length drill आप place करो और निकाल दो. Then start placing your implant. So you'll get a good primary stability, and you will reduce the chances of pressure necrosis, which you will be able to see after 3 to 4 months in your post-surgical radiograph. So that's another trick, and that's about the pressure necrosis. Normally, I personally prefer to place about 0.5 millimeter to 1 millimeter subcrustally because my designs favored it. There are other designs which speaks about metal collar, which is basically for tissue integration. So that's your personal preference. My personal preference is aggressive, active thread, and I personally prefer to place a bit subcrustally. That's a small video. Sorry for video quality. I did this case yesterday and I asked my assistant to record it. So it is shaking too much. That is a sequential drilling, how you're supposed to go at a sequential drilling. First is like something Linderman drill or anything similar to Linderman drill for initial crustal punch. Even lamina dura has a cortical bone, so initial punch you're supposed to give. Then sequentially keep on increasing the size. That's, I always prefer, even though I'm practicing implantologist from so many years, I know the markings, but I always prefer to cross-verify. I do literally in every case. I just keep it, okay, this is 11.5 millimeter, this is 13 millimeter. Do that, that's a good habit. क्योंकि कब दिन बुरा हो आपको पता नहीं है. So it is always a good habit to cross-check everything. Cross-check, I didn't place the radiograph. After that, you're supposed to place a radiograph and cross-check whether you're supposed to go at, you're going in the right direction. That's indicator, pin. I always prefer to keep it at 1200 RPM. I decided to place an implant of 3.75 millimeter, considering the medial distal width of femoral region. So one size less, that is 3.45 is the final drill size which is needed.
ट्रेन कर दो कि दे आर द बेस्ट पीपल, सर प्रोग्राम चेंज करना है. That's a motor driven. Keep the RPM at 5, lower speed RPM, that is 5 to 10. That's a stability we are checking. That's we have achieved 25 Newton centimeter, but I didn't do immediate loading. As I told you that I'm in favor of delayed loading. Most of my cases I always prefer to do a delayed loading. Only if my patient is not from my state, I prefer to go ahead with immediate loading. Cross check with ratchet at 45 Newton centimeter. So that's break of ratchet. It shows that there is a sufficient 45 Newton centimeter. That's the implant which is being placed over there. And then just healing abutment. Again, healing abutment. Normally we take very casually healing abutment. Healing abutment plays a very important role. Trust me, it plays a very important role, specifically if you want to go ahead with a good gingival collar. The selection of healing abutment is very important, like depending on what type of gingival collar you want to go ahead or you want to achieve it, especially if you're planning for a delayed loading. One step, delayed loading. So that's about the surgical case. As I told you, if you're planning for immediate loading, remember one thing. Any micro motion less than 100 micron is tolerable. More than 100 micron, it will lead to the fibro integration. That's a simple thing. So if you are giving a immediate loading in case of full arch, or maybe in case of segment, or maybe in case of pterygoid or zygomatic implant, then when we join them, the micro motion gets limited. So anything less than 100 micron is absolutely acceptable. More than 100 is tricky and difficult. And secondary stability, because of time limitation, I am just going to skip the secondary stability. Only thing you need to remember is the implant design. Selection of implant design is like a secondary stability, and selection of implant design is also important. Most of us, on a basis of our clinical experience, will say, okay, कोई भी implant है, 3 महीने बाद तो उसमें stability आ ही जाती है. What is more important is what is the amount of bone to implant contact. What is the support of literature for that particular implant company? So it has already been shown insufficient amount of literature is there. The machine implant, there is a drop of primary stability over the period of time. Whereas the modified surface, the primary stability is almost constant. Why? Because there is a gradual way. जैसे जैसे primary stability कम होते जा रहा है, वैसे वैसे secondary stability बढ़ता चला जाता है. So I hope you remember this particular. Particular graph, and there is one again slide. What is the histological response of Alpha Bio? In relation to its secondary stability, and how does the implant design, which is basically a nano surface design, how it responds in relation to the secondary stability. So Alpha Bio has shown there is a more than 94% bone to implant contact if done with proper protocol. Because of its design and because of its modified surface, there is a higher amount of bone to implant contact. And this diagram, when I was a student, I never understood this particular diagram, but it will be good that you understand this diagram. This shows, like this blue line depicts the primary stability, whereas the gray line depicts the secondary stability. You will see this is a duration over the period of V. Initially, when you place implant, the primary stability, because of mechanical bone to implant contact, is on very higher side. Whereas secondary instability, where we talk about, it is a biomechanical contact. Means bone is integrated. So there is reduced amount of or secondary stability is almost negligible during implant placement. But over the period of time, there is necrosis, and then there is a reduction of primary stability. But simultaneously, because of modified surface, the primary stability keep on increasing. Secondary stability keep on increasing. As a result, the overall stability is almost to the same level. And that's why selecting a good implant design with a good modified surface is critical if you are planning for immediate loading. If you are going ahead with delayed loading, more or less, most of the implant company will give a successful outcome. But for primary stability or immediate loading, the surface and design of implant matters a lot. So second stage surgery, I need not discuss, just a flap reflection. Only thing we need to discuss in second stage surgery is there are different ways with which you can, the simplest way is give anesthesia, BB blade, reflect it. That's the simplest thing. Now, the thing arises is, like many of my students ask, sir, incision kaise dena hai? Or incision kahan pe dena hai? That is important, because here you should take guidance from your perio colleagues. They will tell you ki incision kahan pe dena hai. If maxillary, give an incision more palatally. Okay, that's simple. Why? Because you want more amount of attached gingiva on buccal side, more amount of attached gingiva on buccal side. So give incision midline se thoda sa palatally. So you'll be able to reflect it. Yeah, I can understand कि थोड़ा सा tissue coverage नहीं रहेगा, but it will heal with secondary intention. So that's about incision. If you are giving a through and through incision, otherwise most of the time locate with probe, our straight probe, locate the implant position, just palpate it. It's quite simple to palpate it. If you palpate, give a cross incision and then reflect it. But you are supposed to give cross incision only if it is your implant is placed exactly at the midline. If you have placed more buccally, if you have placed more lingually, then it is better to reflect the complete flap, because you want to attach gingiva to be over there over the period of time. So that's about incision. They ask me, sir, can we use laser to give an incision? Yes, you can give a laser. It gives a pinpoint, that one. But do not mix your laser puncture with impression. Do not mix, because the company with lasers, they promote saying that कि आपने जिस समय आपने पंचर दिया उसी समय आप impression ले पाओगे. But I'll tell you, the gingival collar is not formed properly. And 100% if you make an impression immediately after giving punch with laser, you will see a loss of adaptation, especially at the cervical region, or there is a more amount of undercut when you call your patient on follow-up visit after 2 months or 6 months or after a year. So it is always better, even if you are using a laser to give a puncture, avoid the impression for at least a week. Place a healing abutment. Healing abutment plays a very vital role. And then when we are placing a healing abutment, again, customized healing abutment, standard healing abutment, there is again a topic which we need to discuss because of time limitation. We are not discussing. Just can I take 10 more minutes? I have been told for 12:45. Just last few slides. क्या हाथ ही निकल गई है, पूछ बचा हुआ है. Because यहाँ से तो prosthodontist आना चालू हो जाते हैं ना. So again, when we are talking about impression, there are different types of impression technique. You know very well, closed tray technique, open tray technique. I'm not going to discuss about the scanning protocol over here because I have been told it is for interns and postgraduate students. So just remember one thing. This is open tray post. This is closed tray post. That's how you are supposed to identify. Open tray post have a long screw. Open tray post have a long screw. Why? Because you need to approach the post outside your tray. We'll see in a video, then you'll understand better. So that's a closed tray impression technique, closed tray impression analog. That's your cast, which depicts the patient anatomy. You place the closed tray impression post, tighten it, not more than 10 Newton, which is your thumb of a student does this mistake. Do remember one thing, if you are making a close tray impression, always remember to block the student. Always remember to block. कुछ नहीं, एक modeling wax को soft करो, press कर दो, वहाँ पे अपने आप वो seal कर देगा. Why it is important? Because obviously you are going to use any kind of, either you are using a light body, or if you are using a putty wash technique, if you are using medium body or heavy body, which is in fluid inconsistency. So वो वहाँ पे भी रिकॉर्ड करेगा और इस इम्प्रेशन पोस्ट की रीसीटिंग को इंटरफेयर करता है, रीसीटिंग को इंटरफेयर करता है. So that leads to accumulation of inaccuracy. So simple step, do remember, before making impression, just block it. So that's after blocking, and that's the impression. After impression, place the lab analog, and then this is a open tray technique. Similar steps. Attach the impression and open tray impression analog. Can you see the open tray impression analog? Block the student. Even if you don't block it, doesn't matter for open tray technique. And yeah, this is important. This is very important. क्योंकि मैं अपने करियर के स्टार्टिंग में कई बार फंस चुका था. So do remember, it is coming out properly. If not, change the tray. If not, change the impression analog. क्योंकि कभी-कभी आप हड़बड़ाहट में ये भूल जाते हो कि उसको एक्सपोज रहना चाहिए अगर आपने ओवर साइज ट्रे ले लिया है तो, और देन गड्ढा खोदो. Try to search where is the impression post. So do remember that it should be exposed. That is the best way. It should come out. It should pop out of the tray level. So that's a step-by-step process for open tray technique. Again, same attachment. A small video which will give you a clear-cut idea about open tray technique. Intentionally kept this particular case because most of the students, we tend to like this, like parallelism is not maintained. Obviously, when the parallelism is not maintained, उस समय जब हम सर्जरी करते हैं तो हमारे दिमाग में रहता है कि किसी तरह से इम्प्लांट चला जाए. But later point of time, while fabricating a prosthesis, the complication arises. This is in this case, how to make an impression. Obviously, there are two ways. Few companies, they provide a plastic impression analog. You can trim down the plastic impression analog. That's one way of doing. But most of the company, they don't provide. So like in this particular case, this was a noble active. And again, he is an endodontist, my student again. और जिस पे इम्प्लांट उसके कलीग ने कॉलेज में ही प्लेस किया था. तो again, I placed a multi-unit abutment for this case to correct the angulation. And anterior one is like again a straight. So can you see the parallelism? Previously it was interfering. So that's another way with which you can do it. I just skip all those things, all the steps. Prosthetic component. Again, I'll skip prosthetic components because there's a huge range of prosthetic component. I hope you understand. Normally I take at least 4 days of lecture in my training classes, which I'm trying to cover in 3 hours, which is next to impossible. But I'll just tell one important slide because this is very important. Most of our implant failure is because of this, which is about implant occlusion. So you need to understand, as I told you in the previous slide, there's a difference between, even though both are for the same purpose, our teeth and an implant supported teeth. Natural teeth and implant supported teeth are for same purpose, but their anatomy is different. And the biggest difference is presence of periodontal ligament, which act as a shock absorber in natural tooth, which is absent. So no periodontal ligament means no shock absorption. That's simple thing which you should keep in mind. And if no periodontal ligament, no shock absorption, it means obviously in any implant supported prosthesis or in natural teeth, we encounter 3 different type of force. One is the occlusal compressive force, second is shear force, and third is the torsional force. Our implant supported prosthesis is meant to withstand only and only for compressive force. No shear force, no torsional force. अगर shear force और torsional force लग रहा है, इसका मतलब मान के चलो कि you will see a crustal bone loss, a clear-cut creator type of bone loss over the period of time. It's time to modify the prosthesis, or it's time to give some kind of aid if patient is a flexor. So just understand this. There is a difference between a shear force and torsional force, vertical force, and implant cannot withstand the second category. It will lead to a bone loss over the period of time. So obviously what you're supposed to do, just remember one thing, if it's a full mouth case, it is bilateral, simultaneous contact, bilaterally, no interference during chewing. Remember one thing, even if you're giving a single unit, no interference during chewing. No interference means side to side. As I told you, it is meant for compressive force. No shear, no torsional force. इसका मतलब क्या है कि आपको जो नॉन फंक्शनल कस्प है उसको फ्लैट रखना है. क्लियर? सिंपल कॉन्सेप्ट. कीप द नॉन फंक्शनल कस्प लेसर कर्वेचर, उतना ही जितना एनाटॉमी में दिख सके कि हाँ ये दांत जैसा दिख रहा है, दांत जैसा दिख रहा है. उसको बहुत सुंदर बनाने की कोशिश मत करो, क्योंकि ज्यादा सुंदर बनाओगे तो हमेशा सुंदरता के साथ खतरा भी रहता है. Okay, jokes apart. Next is about, do remember one thing, canine guided occlusion and groove function. Simple thing is, कभी-कभी मेरे से स्टूडेंट पूछते हैं सर canine guided groove function, anterior guidance सब में देना है. दूसरा canine guidance सब में देना है. If I'm talking about single unit or 1 or 2 implant, okay. लेकिन अगर canine ही compromised है और आपने पीछे इम्प्लांट दे रखा है, तो उस केस में give a group function. If your canine is compromised, give a group function. Otherwise, it's the canine guidance what you're supposed to give. And then, simple concept, keep the contact point as simple as possible. हम नेचुरल टूथ पे या FPD पे क्या करते हैं, ट्राइपोड कॉन्टैक्ट देने की कोशिश करते हैं. बट इम्प्लांट के केस में keep the contact at center. Why? Because if you try to keep a contact at the cuspal tip thinking that you're giving a contact in the functional cusp, a cantilever force will start acting. Slide yaad hai? No shear force. Cantilever is what? It's a shear force. Even a small amount of cantilever will develop a shear force. So keep contact at the center. And then occlusal table should be smaller. जितना बड़ा आपने occlusal table दिया, उतना जितना कम से कम रख सको उतना अच्छा है, within a permissible limit. Now next important thing is, sir, how much, when we are talking about an implant protected occlusion, keep the contact light. होता ये है कि एज अ टीचर हम सोचते हैं कॉन्टेक्ट लाइट रखना रे वो बच्चा यही सोचते रहता है कि सर ने तो बोला है कॉन्टेक्ट लाइट रखना, लेकिन ये लाइट का मतलब क्या होता है? या दैट्स इंपॉर्टेंट. सो I hope you remember this particular point, the difference between a natural tooth and implant. I told you, axially, maximum amount of axial compression is somewhere between 5 micron to 25 micron. Okay, so remember one thing, keep that thing in mind. So how to check that how much contact to give? It's simple. You know your shim stock? You know your shim stock? In fact, many of my PG, they don't know what is the use of shim stock. Sir, ये चमकता है, लेकिन इसमें marking नहीं आती है. Yeah, even when I was student, even as a first year student, second year student, even I too didn't knew कि ये shim stock से marking कैसे लेना है. It is not meant for marking. It is meant for to check the clearance, कि वहाँ पे clearance है कि नहीं है. So that's what you're supposed to do. Shim stock is most of the time, shim stock is 1 micron. आपको क्या करना है? लाइट कांटेक्ट में शिम स्टॉक आराम से खिंच जाए. लाइट कांटेक्ट में शिम स्टॉक आराम से खिंच गया मतलब 8 माइक्रोन का क्लियरेंस तो है ही है. और टाइट कांटेक्ट में शिम स्टॉक अटक गया. डिड यू गेट मी? एंड दिस इज व्हाट इम्प्लांट प्रोटेक्टेड ऑक्लूजन सेज. इम्प्लांट प्रोटेक्टेड ऑक्लूजन सेज कीप अ लाइटर कांटेक्ट. एंड लाइटर कॉन्टैक्ट मीन्स अगर आप उसको टोटली आउट ऑफ ऑक्लूजन कर दोगे तो वो नॉन फंक्शनल हो जाएगा. सो कीप योर कॉन्टैक्ट एज लाइट एज पॉसिबल. सो दिस इज वेरी वेरी इंपॉर्टेंट. दिस स्लाइड इज very important. I'm not going to discuss about further implant different types of occlusion concept in RPD, FPD and complete denture because that itself is a vast topic. And then no cantilever, as I told you, strictly no to the cantilever. आमतौर पे आपका implant is, that's why we say cross is the boss. Prosthetic planning is the most important thing for a successful implantology. Where you're going to place implant, that should be determined first rather than seeing the bone. If you see a edentulous span in 6 region, 6, 7 region or 4 region, then you need to understand that my contact is, मेरे जो teeth का contact यहाँ आने वाला है. अगर मैंने implant उसको थोड़ा सा buccally place कर दिया या थोड़ा सा lingually place कर दिया, it means I'm inviting shear forces. And what that slide said, implants are not meant for shear forces. You will see that if you have placed implant a little bit buccally, lingually, mesially or distally tilted, check your same implant after 2 years. Your radiograph will tell you everything that what mistake you have done. Okay, time limitation. There are few cases, clinical cases, I think we should stop over here, sir. Sorry, ma'am. So just remember one thing. Immediately, you're going to practice throughout your life. Take a gradual step. There is no shortcut to success. आप अपने किसी भी प्रोफेसर से पूछोगे वो यही बोलेंगे कि मेडिकल प्रोफेशन में इट इज़ अ ग्रेजुअल स्टेप. हो सकता है कि कुछ समय के लिए आपको सक्सेस मिलना चालू हो, बट उतनी तेजी से डाउनफॉल भी आना चालू होता है. सो लर्न ग्रेजुअली, do it gradually, follow the standard protocol, no to the immediate loading until and unless you are getting a good clinical condition. Until and unless you are getting a good clinical condition. Don't commit every patient that, okay, आपको full mouth करूँगा मैं, एक दिन में दांत भी दे दूँगा. No, strictly no. That is only for the experienced implantologist. Believe me, there is a hell lot of complication related to full mouth immediate loading. Earlier loading? Probably yes. Why probably yes? Because nowadays there are good amount of implant designs, implant modified surface which are available, which enhances the rate of osseointegration. I didn't tell you that modified surface is basically meant, जो nano surface है उसकी concavity exactly osteoblast के size के हिसाब से रहता है. So that promotes or that attracts more and more osteoblast. And that's the simple concept that why in modified surface we get an enhanced rate of osseointegration. And then progressive loading, that's the ideal line for you. Always and always think about progressive loading. Go gradually. Place implant, wait for 3 months, 4 months, and then go ahead with prosthesis placing. Prosthesis, whether you are giving an immediate final prosthesis or gradually, that is up to you. What I'll suggest for you is, if you are using 1 unit, 2 unit, or bridge in a segment, go ahead with definitive prosthesis after 3 to 4 months. But if you are going for a full mouth, give an interim prosthesis at least for a month. And that will help you to give a long-term predictability. And then Brennemer protocol, still gold standard. Still gold standard. कोई भी केस जिसमें आपके दिमाग में खटक रहा है, पेशेंट को एक्सप्लेन करो. पेशेंट आर वेरी इंटेलिजेंट, बिलीव मी दे विल. पेशेंट को एक ही चीज समझ में आता है कि डॉक्टर आपका भला सोच रहा है या बुरा सोच रहा है. बुरा मतलब पैसे के लिए सोच रहा है कि आपका भला सोच रहा है. अगर आपने पेशेंट को ये कन्विंस कर लिया कि वॉट एवर यू आर डूइंग इज फॉर योर बेनिफिट, दे विल इवन वेट फॉर द गोल्ड स्टैंडर्ड. Okay, so that's a concluding remark. I always owe this person because he is the source of motivation for me, and whatever I learn, yes, for post-graduate student, I don't keep in my other presentation, but for student presentation, why I always keep, see, I am having a practice of almost 17 to 18 years, and believe me, I still encounter complications which I'm not able to handle. If I'm not able to handle, then who will handle? Obviously your boss. Your boss is always boss. A person who is experienced, you need to understand, as your experience is adding, his experience is also getting top up. So if you find any kind of difficulty, if you find any kind of problem, they are the people who will be there. And see, one simple thing which postgraduate student will never understand. They don't expect anything from you. They expect only one thing is respect. Respect now and respect later. Just a simple wish, good morning sir, is more than sufficient for them. And you know, आप लोगों के लिए गुड मॉर्निंग सर बोलना क्यों जरूरी है पता है? इसलिए क्योंकि कॉम्प्लिकेशन अभी नहीं है, क्योंकि अभी तो फंसते हो तो फिर तुरंत वो पेशेंट को छोड़ के भाग जाते हो. पेशेंट को बोलते हैं कि आप 10 दिन बाद आना, और 10 दिन बाद आप अगले डिपार्टमेंट में पोस्टिंग हो जाती है. ठीक है, लेकिन जब आप प्राइवेट प्रैक्टिस की लाइफ में जाओगे, माय स्टूडेंट दे स्टिल कॉल मी एंड आई स्टिल कॉल माय प्रोफेसर इफ आई गेट स्टक एनीवेयर. एंड यू विल गेट स्टक, 100% you will get stuck at any point of time, and only savior will be two things: literature. Keep a habit of reading a literature. I'm very fussy in writing manuscript for publication, but read. They are the best teachers. They are the best teachers. There is nothing is, ऐसा कोई नहीं है इस दुनिया में implant practice का जो literature में ना हो. There is no need for you to listen लिटरेचर। तो अगर आपके प्रोफेसर ये बोलते हैं कि जाओ लाइब्रेरी में आधा घंटा बैठ जाओ, तो उसे सेकेंड ईयर BDS के कॉन्सेप्ट ऑफ अक्लूजन से रिलेट कर लेना, because you don't know the importance. Over the period of time, you'll come to know, and that's last slide. That's all from my side. Thank you very much for your patient hearing. This is my address. You are free to communicate me at any point of time you want. Thank you.
Thank you so much, sir, for the lucid presentation and keeping the audiences hooked throughout the session. I would now request you kindly take your seat. And we'll move for the live demonstration session. We just take 5-10 minutes for setting up the technical team. And after the live demonstration session, we'll be having a QR code displayed on the screen. You have to scan the code, and then only you'll be getting your attendance certificates. I repeat, we'll have a QR code on the screen displayed after the live demonstration session, which you have to scan to get your attendance certificates. So please bear with us while we prepare for the session.
introduce this particular kit. This is one kit from Alpha Bio. This is basically a starter kit. And just to introduce about this particular, this is a ratchet, which is a broken arm type of ratchet. Broken arm means, okay. And then you have depth gauge. Yeah, this is the depth gauge. If you see, there is a narrow side and this is a broad side, and it has a multiple markings on it, which is 8, 10, 11.5, 13, 16, and 18. And then there is a sequence of drills over here. This is Linderman drill, which is initial punch drill. And then all these are step drills. Over here, if you see, over here, if you see, this is, okay, paralleling pins. And then at the bottom over here, there are 3 different components. Obviously, this is a screwdriver. Manual screwdriver, this is a ratchet driver, and this is implant driver. This is an implant driver. Yes, there is one more thing which I wanted to tell you is, like, if you see a full-fledged one implant kit, there are a few more things which you will be able to see. The top row which you can see over here is basically for the step drills. Over here in the bottom, they will have one more set of drill, which is a standard drill. I have already told you in the presentation the difference between a standard drill and step drill is, you can see over here, this step drills. Can you see there is a step, 2 different diameter. The bottom is different diameter, where rest of the implant is different diameter. But all these are tapering type. All these are tapering type. And then over here, there are 3 different color coding. One is purple, green. इस वाले को कौन सा कलर बोलेंगे अपन? Yes, any PG student. अरे कोई difficult वाइवा नहीं है, हाँ? जो भी बोलो, हाँ? Okay. थोड़ा अंग्रेजी में कम है. Okay, this is there is a magenta. This is magenta color, na? Okay, this is purple color. Okay, so this is purple color. Hindi एकदम आसान है, बैंगनी color. Okay, so this is purple color, and over here green color. There is the Alpha Bio has a multiple implants with it. They have eyes, they have SPI, they have Neo. Now they have a Nina also, and each of this implant system has a 3 different set of hex connection. One which is called as internal hex, second which is called as conical hex connection, and third which is called as conical connection, conical narrow diameter connection. So this particular purple color is basically, यहाँ पे अगर जितनी भी armamentarium आपको purple color का दिखाई देगा, this is basically meant for hex connection. Interesting thing is, all the Israeli system, whether you talk about Norris, whether you talk about Eden, whether you talk about BioLine, all this have hex connection. तो आपके पास अगर ये किट है, तो उस वाले सिस्टम में भी ये सारी चीजें कंफर्टेबल होंगी. Green color is basically for the Neo, which is having a conical hex connection. Top part is conical and bottom there is a hex on it. So आपको इसी set of instruments में यहाँ पे भी मिलेंगे. What you have got is over here is an implant driver, which is purple color. Same thing, you'll have a green color, metallic green color. One is of short height, other is of long height. आमतौर पे short height edentulous posterior में काम आता है, long height dentulous posterior और anterior region पे. That's common sense. जब आप use करोगे तो उस समय आपको खुद ही समझ में आती है कि कौन सा क्या use करना है. This is ratchet attached driver, and then this is unigrip manual driver, screwdriver. And there is one more component over here is drill extender. So imagine करो कि आपको first molar region पे implant place करना है. There is a premolar which is slightly supra erupted, and if it is supra erupted, it will be tricky for you to use this 18 mm drill. उस केस में आपको ये 18 mm drill यूज करने में दिक्कत जाती है. then in that case you can use this drill extender, just attach it, slightly rotate it, and now you have a long length drill with you. Okay, so this is drill extender. और कभी कभी क्लिनिकली अगर इसमें ब्लड चला जाए तो उसको निकालने में जान निकल जाती है. यूज अ गॉस, थोड़ा सा सलाइन से क्लीन कर लो और वो निकल जाएगा. सरफेस टेंशन. So that's about a drill extender. Now, as I told you, your osteotomy should be a sequential drilling. Why sequential drilling? To get a accurate osteotomy, gradual preparation, and most important thing is to reduce heat generation. Imagine करो कि आपको 4.2 का इम्प्लांट प्लेस करना है. आपने पायलट ड्रिल यूज किया और उसके बाद डायरेक्टली आप 4.2 का यूज कर रहे हो, which is practically impossible. So you keep on doing a sequential drilling, 1, 2, 3, 4, 5, 6, 7. There is no shortcut. Never ever take shortcut. ये भी नहीं सोचना कि अरे ये बोन की डेंसिटी तो कम है, मैंने 2.8 यूज किया, अब डायरेक्टली 3 पॉइंट यूज कर लेता हूँ या कर लेती हूँ. डोंट डू दैट. फॉलो द गोल्डन रूल, फॉलो द स्टैंडर्ड रूल. हार्डली क्या है, 5 मिनट ही बचाओगे आप. So let's see, this is a model. We can place, we got only one implant, so we can place either in the anterior and posterior region. Yes, कौन से region पे आगे place करें कि पीछे place करें? हाँ? Posterior. Okay, we'll go ahead with the posterior placement. Now, what is the implant size? What I got is 4.2 into 11.5. See, the planning is most important. आपने IOPA से या CBCT से बोन को एग्जामिन किया, वहाँ पे आपके पास जो फेवरेबल बोन है 4.2 अगर आप प्लेस कर रहे हो तो 1.5 ऑन लिंगुअल, 1.5 ऑन बकल. इसका मतलब CBCT में आपको कम से कम कितना विड्थ दिखाई देना चाहिए? 4 + 3, कम से कम 7 मिलीमीटर का विड्थ आपको क्रिस्टल लेवल पे दिखाई देना चाहिए. अगर आपको 4.3 से 7 मिलीमीटर से कम दिखाई दे रहा है तो आप उसको हल्का सा प्रिपेयर कर सकते हो, प्लेटफॉर्म क्रिएशन कर सकते हो. आमतौर पे फुल माउथ के केसेस में हम 100% करते हैं. सो दैट विल गिव यू अ लिटिल बिट वाइडर, बट डू नॉट डू ओवर प्रिपरेशन और अदर देन आप बोन ऑगमेंटेशन को फॉलो करो. ओके, बिकॉज देयर आर फर्दर कॉम्प्लिकेशन अगर आप एक लिमिट से ज़्यादा प्रिपेयर करोगे तो. सो हमें दैट इज़ द नेक्स्ट थिंग व्हाट वी डिसाइड. हम एक बार इम्प्लांट का डायमेंशन डिटरमाइन किए. इमेजिन करो कि हमने 4.2 into 11.5 डिसाइड किया. नाउ एज आई टोल्ड यू कि देयर इज समथिंग कॉल्ड एज लिंगुअल कॉन्केविटी, सबमैंडिबुलर फॉसा. तो आपको उस कॉन्केविटी का खास तौर पे ख्याल रखना है. अब CBCT इज द ओनली वे विच विल हेल्प यू टू डिटरमाइन देयर इज अ सबलिंगल कॉन्केविटी. अगर सबलिंगल कॉन्केविटी है तो आपको आपके प्रोस्थेसिस को उस बोन के हिसाब से गाइड करना पड़ेगा. आपका जो प्लेसमेंट है वो उसी के हिसाब से ही होगा. कभी कभी हमें थोड़ा सा कॉम्प्रोमाइज सिनारियो पे जाना रहता है. तो उस केस में नाउ अगर ये मॉडल मेरे पास आया है, यू कैन सी देयर इज अ गुड अमाउंट ऑफ कॉन्केविटी ओवर हियर. एंड इमेजिन करो कि मैंने यहाँ से पोस्टीरियर रीजन पे बिल्कुल स्ट्रेट इम्प्लांट प्लेस किया तो 100% मैं लिंगुअल कॉर्टेक्स को परफोरेट कर दूंगा. So what I'm supposed to do is, I'm supposed to slightly keep it buccally. मैं जो एपेक्स है उसको थोड़ा सा बकली प्लेस करूंगा. मतलब मेरा ड्रिल जो है लिंगुअल साइड से थोड़ा सा बकली होता हुआ जाएगा rather than going straight. Okay. I'm not used to this physio dispenser, but it should be more or less same. If you can see this physio dispenser, there is a top one marking which shows RPM, means आपने जिस speed पे set किया है. As I told you, anything less than 2000 is more than sufficient. Next is about the gear, 20:1, because your reduction gear handpiece just अभी कुछ latest handpiece आ रहे हैं जिसमें multiple settings हैं. Otherwise मोस्ट ऑफ द गियर जिसमें है जो लिखा रहता है, अच्छा इसमें नहीं है. अदरवाइज आप किसी भी अच्छी कंपनी का लिखोगे तो उसमें रिडक्शन गियर कि रेशियो ऑलरेडी लिखा हुआ होगा कि ये हैंड पीस कितने रेशियो पे चलने वाला है या कौन कौन से रेशियो पे चल सकता है। तो उसके हिसाब से आपको आपके इस पर्टिकुलर सेटिंग को सेट करना है। नेक्स्ट इज टॉक, व्हाट टॉक यू आर प्लानिंग। As I told you, keep a torque of maybe 25 Newton centimeter at the initial level. That is more than sufficient. 25 का टॉर्क मिलने के बाद आप उसको या तो मोटर ड्रिवन नेक्स्ट सेटिंग जो है वो 40 या 45 पे रख सकते हो या 35 पे रख सकते हो, बट कीप 25 न्यूटन सेंटीमीटर एज अ स्टैंडर्ड वन बिकॉज दैट विल हेल्प यू टू गेट अ गुड प्राइमरी स्टेबिलिटी। अगर आपने डायरेक्टली 40 पे सेट करके रखा हुआ है तो आपका इम्प्लांट 40 पे जाता रहेगा और आपके बोन को 25 से सरपास करते हुए वो ओवर प्रिपेयर। इनफैक्ट द इम्प्लांट, मोस्ट ऑफ द इम्प्लांट व्हाट वी आर यूजिंग इज सेल्फ टैपिंग। वो अपने में एक ड्रिल की तरह काम करता है। तो इमेजिन करो कि आपने इसको 40 पे सेट किया हुआ है और वो 40 के टॉक तक घूमता ही रहेगा। डिड यू गेट मी? तो अगर आपका एपेक्स 11.5 मिलीमीटर आपने प्रिपेयर किया है, हमारा जो रिक्वायरमेंट प्राइमरी स्टेबिलिटी के लिए कितना है 25, एटलीस्ट 25 न्यूटन सेंटीमीटर, ये 40 तक घूमता रहेगा, मतलब आपकी जो प्राइमरी स्टेबिलिटी को सरपास कर देगा। दैट्स अनदर इम्पॉर्टेंट थिंग जो आमतौर पे हम फिजियो डिस्पेंसर की सेटिंग पे ध्यान नहीं देते। ओके, इट्स बीन सेट एट 600। अगर ये मेरा फिजियो डिस्पेंसर रहता तो मैं शायद इसको 800 या 1200 पे सेट करता। मैं उसे छेड़खानी इसलिए नहीं कर रहा हूँ क्योंकि मुझे इसका कंट्रोल नहीं पता। अगेन देयर इज नथिंग मच, हैंड पीस एंड इट हैज इनबिल्ट इरिगेशन ओवर हियर। सो जो आपका इरिगेशन ट्यूब है वो एक्सटर्नल इरिगेशन, आप जो यूज करते हो वो सिर्फ और सिर्फ एक्सटर्नल इरिगेशन है। सिर्फ कुछ सिस्टम ही ऐसे हैं जिसमें इंटरनल इरिगेशन रहता है। देयर आर ओनली फ्यू सिस्टम्स व्हिच हैज इंटरनल इरिगेशन। एंड हाउ विल यू डिफरेंशिएट द इंटरनल इरिगेशन एंड एक्सटर्नल इरिगेशन? ये जो ड्रिल बिट है उसके सेंटर पे आपको एक वेंट दिखाई देगा। सो दिस ड्रिल बिट इज बेसिकली मेंट फॉर एक्सटर्नल इरिगेशन बिकॉज इट्स सॉलिड फ्रॉम इनसाइड। सेम, पुश बैक एंड देन अटैच इट। सो विल स्टार्ट विथ Lenderman drill. And if you see this kit has a scale at the bottom. Can you see over here? इस बॉटम पे यहाँ पे स्केल है यहाँ पे। सो आप द फर्स्ट इम्पॉर्टेंट थिंग इज, एज आई टोल्ड यू, दिस ड्रिल हैज अ मार्किंग। अदरवाइज मोस्ट ऑफ द लेंडरमैन ड्रिल में मार्किंग नहीं रहता। अगर मार्किंग नहीं है तो ऑलवेज प्रेफर टू टेक अ शॉर्ट लेंथ रादर देन टेकिंग अ लॉन्ग लेंथ। दिस विल प्रिवेंट अ एक्सीडेंटल इंजुरी टू एनी वाइटल स्ट्रक्चर। सो as we decided 11.5 millimeter, keep this drill always little bit short. So I'll prefer to keep around 10 millimeter. Now if you see from the bottom, इसको अपन zoom कर सकते हैं क्या? So this is a marking. First marking is 6 millimeter. The second marking is 8 millimeter. Third marking is around 10 millimeter. Yes, third marking is around 10 millimeter and fourth marking is around 11.5 millimeter. Can you see? 0 से मैंने रखा, yeah. Okay, so this is how you are supposed to. I always prefer to keep a endo scale. That is much more convenient and it can be sterilized, metallic endo scale. So हमें buccolingual जो क्राइटेरिया हमने बताया था कि 1.5 millimeter on the both the side, keep it. And now since we know there is a concavity, I'll keep the angulation this way. Can you see this? Keep the angulation little bit this way because I want to avoid lingual concavity. It is very very easy to do it over here क्योंकि हम इससे जैसे ये होता है ना, फाइनल ईयर में टाइपो प्रिपेयर कर रहे हैं, हाथ में लेके पूरा आर्ट वर्क सब डायरेक्शन में कर लेते हैं। So it is somewhat similar to this. Yeah, now I'm 10 millimeter. I'll stop over here. Okay. Now this punch will reduce the interference and it will also guide my initial 2 mm drill. 2 mm drill, as it says 11.5 millimeter. Now if it is 11.5 millimeter, again you need to think about your concept, how you are supposed to place implant, whether you are placing equicrustal or whether you are placing subcrustal. Supracrustal का सवाल ही नहीं उठता because this design is not meant for supracrustal. है ना? So this is either it can be placed equicrustal or it can be placed subcrustal. What I have seen with Alpha Bio Noble Active implant, specifically Alpha Bio implant, is they have a top concavity and they provides a good seal, bone का एक seal बनाता है on the platform side. So I always prefer to place at least 0.5 millimeter subcrustally. So if my length is 11.5 millimeter implant, which I have decided, what should be the drilling depth? 11.5 plus 0.5 or maybe about a 1 millimeter more than this. So this is, let's just see measure. Can you see this marking? Over here, I'll just remove from the handpiece and then you'll be able to see. Okay, I'll just keep it and then you'll just try to correlate over here, the markings. So if you see the first ring, it is exactly at 6 millimeter. The second band, yeah. So first marking is 6 millimeter, second marking is 8 millimeter, third marking, which is a broad silver step, which is 10 millimeter. उस step के बाद एक पतला और marking है, that is 11.5, and next broad silver marking की जो starting है वो 13 millimeter है. So as I told you, 11.5 millimeter, this is what I decided. So I'll do a osteotomy little bit more than 11.5 millimeter, less than 13 millimeter. So we are going to start. Yes, लिख रहे हैं? Yeah. So I'm going. First marking 6 millimeter. Can you see this 6 millimeter is gone? Then second marking, which is 8 millimeter, gone. Third marking, millimeter, gone. See, it's simple rule. Whenever you are drilling, especially in the complete edentulous area, your complete focus should be in the marking. And you should start playing with your hand regarding the orientation. कि आपका जो hand का orientation है, आपको ये ध्यान रखना है कि मैं mesially या buccally, distally तो नहीं जा रहा हूँ. साथ ही साथ क्या मैं lingually या buccally तो नहीं जा रहा हूँ. जैसा exactly मैंने प्लान किया था CBCT में या किसी भी रेडियोग्राफ में, मैं क्या exactly उसको फॉलो कर रहा हूँ कि नहीं कर रहा हूँ. सो यू कैन सी कि मैंने जब प्लान किया था स्ट्रेट, सिंस दिस इज कंप्लीट एडेंचुलस, तो मेरे लिए ज़्यादा आसान है. बट अगर ये रियल सिनारियो रहता तो यू नीड टू बी केयरफुल कि आपका ड्रिल जो है मीजियो डिस्टली जो एक्सपेक्टेड है उसके सेंटर पे जा रहा है कि नहीं जा रहा है. एंड देन नेक्स्ट इज 11.5. Can you see 11.5 millimeter gone? Yeah. And the next marking is 13 millimeter. So I'll go a little bit more than 11.5 millimeter. Yeah. So a little bit more than 11.5 millimeter. And what did I violate? I violated more than 5 seconds of drilling. What you are supposed to do is, since this is the initial drill, that's fine. But जब आप subsequent drilling करोगे, तो see this should be. Can you see this? So when you are doing this, already आपका pilot drill में एक path बन चुका है, and when you are doing this, जो इरिगेंट है, जो आपका सलाइन है वो सॉकेट के अंदर लगातार जा रहा है. So that's done. Now next is, if you see this 2 millimeter, it is done. The next drill is 2.4, 2.8. If you see, there are two different marking which is written diameter. Pi का shape बना हुआ, that is the diameter 2.4, 2.8. 2.4 means apex में 2.4 है और rest of the drill में 2.8 है. Till 11.5, little bit more than 11.5. Done. How much time it took? Less than 5 seconds. So by default, we are following the standard protocol, 5 seconds of drilling and wait for 10 seconds of cooling period. Next drill is 2.83. Again, it's a good habit कि जो ड्रिल आप जहाँ से उठा रहे हो एग्जैक्टली उसको वहीं पे वापस डालो. नॉट जस्ट ड्रिल, इवन द रैचेट, एनी इंस्ट्रूमेंट. इन फैक्ट दिस इज द अटमोस्ट केयर विच आई डू कि अगर मैं अपना पेरियोस्टल एलिवेटर उठा रहा हूँ तो यूज़ करने के बाद मैं उसको ट्रे में वहीं डालता हूँ. इट्स अ गुड हैबिट. वाई? हालांकि मुझे मेरे बॉस ने मेरे को उस चीज़ के लिए मल्टीपल टाइम पनिश किया था, उसके बाद ये सीखा. But the important thing is that imagine if you are placing multiple implants और आपके असिस्टेंट, आमतौर पे असिस्टेंट उतने नॉलेजेबल नहीं रहते हैं, कभी कभी उनको नॉलेज होने के बावजूद भी वो गलती करते हैं. तो इमेजिन करो कि आपने ये ड्रिल यहाँ पे रख दिया और उसके बाद नेक्स्ट इम्प्लांट के आप सिक्वेंशियल ड्रिलिंग कर रहे हो, आपने धोखे से एक साइज ओवर ऑस्टेटोमी कर दिया. अगला इम्प्लांट इमेजिन करो कि 4.3 की जगह आपको 3.75 प्लेस करना है, तो आपने बाय डिफॉल्ट ओवर ऑस्टेटोमी कर दिया. सो इट्स ऑलवेज गुड हैबिट कि इफ माय दिस ड्रिलिंग इज कंप्लीटेड आई एम सपोज टू रीप्लेस इट बैक एग्जैक्टली एट द सेम पोजीशन. ओके, वो आपको उस ऑस्टेटोमी के लिए भी मोटिवेट करता है, ये हेल्प करता है. सो नेक्स्ट ड्रिल इज 2.8, 3.2. टू 3.2, 11.5 की मार्किंग, उससे थोड़ा सा ज़्यादा, एंड दैट्स डन. One very good tip: never ever rely on assistant. Never ever rely on assistant, and never ever rely on junior PGs. क्योंकि एज अ सीनियर पीजी आप इम्प्लांट प्रैक्टिस किए हो और एक दिन पहले एक फीलिंग आती है कि कल मैं एक बहुत बड़ा इम्प्लांटोलॉजिस्ट बनने वाला हूँ. तो यू आस्क योर जूनियर पीजी टू सेट द किट, और उस बेचारे को क्या पता कि जो ग्रीन बैंड है वो 3.2 का है. वो सिर्फ एक छोटा सा काम करेगा कि इसे यहाँ रख देगा और इसे यहाँ रख देगा. इसका मतलब क्या? इसका मतलब अगले दिन आपका सत्यानाश होने वाला है. और दूसरा जो इंपॉर्टेंट चीज है, ये जो मैं बता रहा हूं ये सत्य घटनाओं पे आधारित है. सो कमिंग बैक, तो देखो आई डिड मिस्टेक अगेन. सो 3.2, 6.5. Yes, done. Now, if this is D2 type of bone or D3 type of bone, I won't do any more osteotomy. इफ इट इज D1 टाइप ऑफ बोन, अगर मैंने एंटीरियर में प्रिपरेशन किया होता तो मैं एक साइज और ज़्यादा मतलब 3.65 to 4.1 जो है डायमीटर, वो उस साइज तक ऑस्टियोटोमी करता। ठीक है, सो नाउ लेट्स सी वन ऑफ योर संदीप, अपने पास यहाँ पे मोटर ड्रिवन ड्राइवर नहीं है क्या? है इसमें? नहीं, इसमें नहीं है, अलग से है क्या? कोई बात नहीं। सो नाउ इफ इट इज मोटर ड्रिवन, व्हाट आई विल डू इज कि मैं इसकी सेटिंग को चेंज करूंगा। इसकी सेटिंग को चेंज करके, ये प्रोग्राम लिखा हुआ है, यस, कैन यू सी दिस स्पीड 20 RPM, speed 15 RPM, that is acceptable for implant placement. I'll just show you the difference. I'll place this drill and see the speed. This is very much acceptable for implant placement. Can you see this? This is well controlled. जब आप implant place कर रहे हो तो इसी speed में place करना है. We'll switch to other program. Imagine करो कि ये 590 and see the speed over here. आपका इम्प्लांट जुप से अंदर चला जाएगा, और अगर वो D4 बोन है तो वो सीधा साइनस में जाएगा। अगेन ये जो सारी चीजें मैं बोल रहा हूँ सब सत्य घटनाओं पे आधारित है, मजाक नहीं है। ठीक, सो यू नीड टू बी केयरफुल। यहाँ पे इट इज ऑलवेज अ गुड हैबिट कि ट्रेन योर असिस्टेंट कि वेन एवर यू आर प्लेसिंग एन इम्प्लांट, चेंज द सेटिंग टू एटलीस्ट ही और शी विल इंस्ट्रक्ट यू कि सर सेटिंग चेंज करना है, क्योंकि कभी कभी हम इंडल्ज रहते हैं, हम थोड़ा सा उस चीज़ को बाईपास करते हैं। सो दैट्स डन एंड नाउ वी विल गो अहेड विद इम्प्लांट प्लेसमेंट। अगर ये मोटर ड्रिवन रहता तो एक मोटर ड्रिवन का कंपोनेंट आपको दिखाया था, प्लेस इट ओवर देयर, पिक अप द इम्प्लांट एंड देन गो अहेड विद द प्लेसमेंट ऑफ इम्प्लांट ओवर देयर इन अ प्री डिटरमाइंड osteotomy site which we have already done. If not, now we are doing a motor driven. If you see the Alpha Bio has a good 3 cover. Open the top paper cover, that's done. And then from here onwards, this is unsterile. So once you open it over here, what your assistant will do is, he will open and he or she should drop it in this way in a sterile atmosphere. इसको ऐसे निकालने की कोशिश नहीं करना है ना. So drop, same thing how you handle BP blade. Okay, same way you are supposed to do this. Now this is a sterile which only an implantologist should handle this particular cover. So that's the advantage of Alpha Bio. Now if it is manual driven, now there is one more component which is not over here. Now if you see this is a driver which is basically meant for ratchet. Now interesting thing is कि इसी में एक unique grip driver भी आता है जिसे जो कि actually implant carrier होता है. So what is difference between this one and other one which is having a grip? Both of them will look exactly same, but इसमें implant का grip उतना अच्छा नहीं आता है. There are chances you will see कि most probably अभी मैं आपको करके दिखाऊंगा. जब इसको प्लेस करेंगे तो देयर आर चांसेस कि वो वहां से गिर रहा हो बार बार. ठीक है. सो व्हाट यू आर सपोज टू डू इज यू आर सपोज टू गेट दैट पर्टिकुलर ड्राइवर विच इज बेसिकली meant टू engage the implant, pick it and place it in the socket and then remove it. रिमूव करने के बाद आप इसे वापस वहां पे प्लेस करो और फिर रैचेट से टाइट करो. डिड यू गेट मी? सो maybe if it is not in the kit, you can request Sandeep to get that particular driver. I forgot the name. So you'll see the difference. Okay. Now this is new one, so it is engaging very well. But जैसे जैसे आप इसको यूज करते चले जाओगे, but obviously it is being used multiple time और उसमें फ्रिक्शन की वजह से जो एडाप्टेशन का लॉस होता ही है, खासतौर पे व्हेन यू आर गिविंग अ हाई टॉर्क, तो उससे ये जो कनेक्शन है, आई एम सॉरी है ना, मैं सिर्फ ये डेमो पीस है इसलिए मैं हाथ में पकड़ के दिखा रहा हूँ, अदरवाइज यू आर नेवर सपोज टू डू दैट. सो दिस ग्रिप, इमेजिन करो कि ये ग्रिप थोड़ा सा पुअर रहा, तो आपने यहाँ से निकाला और सॉकेट के पहले ही वो टेबल पे गिर गया. सो देयर इज अनदर गुड वे टू डू इज, इफ यू आर यूजिंग this goes for almost all the implant system. Hold it this way. Simple technique. इससे गिरने के चांसेस कम रहेंगे. अब ये नहीं बोलना कि सर वहाँ पे कैसे करोगे करके, तो वहाँ पे केयरफुली ले जाओ और हल्का सा आपको एंगेज करना है यहाँ पे, एंड देन जस्ट प्लेस इट. क्लियर? अदरवाइज यूज द यूनिग्रिप ड्राइवर एंड देन मैनुअली आप उसे प्लेस करते चले जाओ. ऑब्वियसली यू नो वेरी वेल द मैक्सिमम अमाउंट ऑफ टॉर्क विच यू कैन अप्लाई विथ योर फिंगर प्रेशर इज about 10 Newton centimeter, except prosthodontist and oral surgeon जो कभी कभी 20 न्यूटन के आसपास भी प्रेशर अप्लाई कर लेते हैं, क्योंकि जब आप उसको टाइट करोगे और रैचेट में चेक करोगे तो 20 न्यूटन. इसलिए जो पंच पेयर में वो होता है ना, ब्रिक, वेट ब्रिक को पकड़ने वाला, उसमें किसी भी प्रोस्थोडोंटिस्ट को पार्टिसिपेट मत करने देना. दे विल 100% विन. Okay, so did you see this? Once it has been placed, now what I'm supposed to do is use the ratchet, and this ratchet has a multiple serration over here. This serration is basically you can adjust the torque. Okay? So we'll start from the very basic. This is zero torque. Then if you see over here, there are marking 10, 20, 30, 40, and infinity. Can you see this? 10, 20, 30, 40, and infinity. Okay? Whereas on this side, there is further more marking, which is half of the interval of those two 10 segment marking. तो इसका मतलब आप 5 के मल्टीपल पे टॉक को सेट कर सकते हो. So initial one it is 10, then 15, 20, 25, 30, 35, 40, 45. और 45 के ऊपर जो है वो सीधा इन्फिनिटी है. ठीक है? आप इस रैचेट में 45 के ऊपर सेट नहीं कर सकते, और बाय डिफॉल्ट 45 के ऊपर सेट करने की जरूरत भी नहीं पड़ती. अगर 45 से ज़्यादा रेजिस्टेंस आ रहा है, reverse it, remove the implant, do a little bit of osteotomy to the next size, and then place it back. Okay, so I'll set to 25. Can you see? मैं जैसे जैसे रोटेट कर रहा हूँ, ये जो बीच की मार्किंग है वो ऊपर जा रही है. Now this marking is set to 25. Now another thing which you need to remember is out and in. ये भी कॉमन मिस्टेक करते हैं. मतलब एज अ स्टूडेंट हम सारे पॉसिबल गलतियां कर सकते हैं, वो करते हैं, और ये एक्सपीरियंस इम्प्लांटोलॉजिस्ट भी करते हैं. सो दिस इज आउट एंड दिस इज इन. इफ इट एंड दिस इज एडवांटेज एक्चुअली. सो इफ इट इज आउट, इट मीन्स जब आप ऐसे रोटेट करोगे तो सिर्फ ये रिवर्स में ही रोटेट होगा. अगर आप इन के साइड पे रखोगे, ऊपर की तरफ इन रखोगे, then it will rotate in a clockwise direction. So in, adapted, placed, and then keep on rotating. So can you see? Arm broke. It means I got the primary stability of, yes. Now what I'll do is I'll change it to 45. Now I changed it to 45. Clear? Now I'll start placing it. Can you see? Now this is the problem. Somebody was asking me about the same thing. Now can you see there are two more threads which is still pending over here? And if you apply more torque, it's a trouble. But I'll tell you from my experience. अगर सिर्फ एक दो थ्रेड बचा हुआ है, उसको इन्फिनिटी में डाल दो और टॉप कर दो. लेकिन अगर सिर्फ आधा जा रहा है, तो इट इज ऑलवेज बेटर टू रिमूव. खासतौर पे D1 रीजन पे रिमूव इट. डू एन ऑस्टियोटोमी लिटिल बिट मोर. हाउ मच टू डू इट? I'll just remove it and then I'll show you. Now this is, now if I want to remove the implant, what I'll do is out, ठीक है, and then reverse torque it. Out, reverse torque it. Take out carefully. इसमें भी यूनिग्रिप यूज करो. डोंट यूज दिस इम्प्लांट ड्राइवर. सो यूनिग्रिप इज मच मोर स्टेबल. स्लाइटली आप चाहो तो सलाइन से इसको क्लीन कर लो, फ्लो करके, एंड देन केयरफुली replace over there. Leave it. Take next size as osteotomy. And this is what I was telling you, कि अगर रेसिस्टेंस एक लिमिट से ज़्यादा है, हमने क्या लेंथ डिसाइड किया है? 11.5. हाउ मच वी आर सपोज टू प्रिपेयर? मे बी हाफ ऑफ दैट. That's all. And now we will just replace the same implant. If you have got a motor driven, that is very beautiful. Motor driven में आप उसको रिवर्स में सेट कर दो, आराम से स्मूथली निकल जाता है, आपको कुछ भी करने की जरूरत नहीं है. बट अगेन मोटर ड्रिवन के बहुत सारे एडवांटेजेस हैं. दैट कीप्स योर वन हैंड कंप्लीटली फ्री. और खासतौर पे मैक्सिलरी पोस्टीरियर में आपको प्लेस करना है, तो सी टू दैट इट शुड बी मोटर ड्रिवन. ओके, एंड देन now implant is almost completely gone, and I got 45 millimeter of primary stability. Can you see this? And जो लास्ट का अगर थोड़ा बहुत बचा हुआ है, तो अगर आपको सबक्रस्टली प्लेस करना है, फाइनल सेट इट टू इंफिनिटी. एंगेज करो उससे पहले, एंगेज्ड, एंड देन गिव अ टॉक टू इंफिनिटी. प्लेस इट सबक्रस्टल. So I've got a good primary stability. Okay, just follow the standard guideline and rules. You'll be able to get a good primary stability. Now, कभी-कभी extraction socket में हमें primary stability नहीं मिलती है. I told you, if you have selected a good company implant, अच्छे से approximation कर दो और भूल जाओ. बशर्ते आपने सॉकेट को अच्छे से क्लीन किया है, वो सॉकेट में फ्लैप आपने अच्छे से अप्रोक्सीमेट किया है. Just need not worry, because it will heal by secondary intention. If you are in doubt, rather than 3 months, go ahead with for 4 months. जो सेकेंड स्टेज सर्जरी आपको करनी है, वो 3 महीने की जगह 4 महीने बाद करो. So that's लिटरेचर में कहीं नहीं दिया ना. This is just I'm telling from my experience. So just go ahead with this. Now once you are done with this, do we have any prosthetic component? Can I get? Now, if I'm doing, acha, oh, sorry. Now, I told you about 2 things. Implant placement, 1-stage procedure and 2-stage procedure. If I'm doing 1-stage procedure, there is a cover screw over here. Can you see this cover screw? Yes. So cover screw, take it out, use the cover screwdriver. Okay. Again, with experience, वो आपका हाथ हमेशा ऐसा ही रहेगा. आप कभी भी ऐसा करने की कोशिश नहीं करोगे. So it is better to keep this way. क्योंकि यहाँ अगर ओरल कैविटी में ले जाके गिर भी रहे तो वहीं गिरेगा, लेकिन अगर यहाँ से आप ऐसे पकड़ के चलोगे तो बीच में नदियाँ और पहाड़ भी आता. Okay, so you don't want your cover screw to get any kind of like on soil and then you're in mess. So place it over there and just tight it. 10 Newton centimeter, that's sufficient. Or approximation, that's sufficient. There's nothing needed. Agar this is, and then close the flap. If I'm doing one stage procedure, rather than placing a cover screw, I'll place a healing abutment. Cannot see healing abutment in there. Healing abutment नहीं है कहीं पे. So you have already seen healing abutment. If I'm doing a one-stage procedure, one-step procedure, it means I don't want कि 3 महीने बाद मुझे फिर से सर्जरी करने की जरूरत पड़े. Simple rule. If you are doing implant placement in edentulous area, you can afford to place a healing abutment. अगर आप एक्सट्रैक्शन सॉकेट में कर रहे हो तो थोड़ा सा सोच समझ के करना. अगर आप एक्सट्रैक्शन सॉकेट पे कर रहे हो तो इट इज ऑलवेज बेटर टू गिव अ कस्टमाइज्ड हीलिंग अबटमेंट और हीलिंग अबटमेंट विथ लार्जर डायमीटर विच कंप्लीटली कवर्स द सॉफ्ट टिश्यू एरिया. अगर आपने वहाँ पे नैरो डायमीटर हीलिंग अबटमेंट डाल दिया तो मान के चलो कि आपको फाइनल इम्प्लांट में थोड़ा ना थोड़ा बोन लॉस दिखाई देगा. ऐसा इसलिए yeah, so this is a healing abutment you can see over here, and if I'm doing a one-step procedure, I'll just place the healing abutment over here. Extraction socket, it will heal. If it is flap, I'll close the flap and this part will be exposed. Cross incision, this part will be exposed. So that's purely up to you. That's simple placement of healing abutment. Okay. Second stage में आपको healing abutment, अगर आप 2 stage procedure कर रहे हो, 3 महीने बाद या 4 महीने बाद जब implant integrate हुआ है, reflect the place, flap and place the healing abutment. So that's all. And then call after 7 days of healing abutment placement. जब एक gingival collar बन चुका है, place the impression analog. You can see over here, this is open tray impression analog. Why? Because screw is little bit longer beyond the impression abutment. So I'll place, this is tricky and important. You have placed it. Imagine करोगे soft tissue वहाँ पे. So again, it is a good habit कि जब आपने impression analog place किया है, tighten it, take a radiograph. Take a check radiograph just to make sure your impression analog is sitting properly. कभी कभी वहाँ पे bone grow नहीं, bone थोड़ा सा overgrow हो जाता है, and that interfere with the impression analog placement. अगर bone grow हुआ है तो there are very high chances कि आपने जब healing abutment place किया है उसके 3-4 दिन बाद पेशेंट आपको फोन करेगा, सर वो आपने पिन प्लेस किया था वो तो निकल गया. और अगर पेशेंट आपको ज़्यादा शॉक देने वाला है तो आपको ये बोलेगा, सर वो आपने इम्प्लांट डाला था वो इम्प्लांट ही निकल गया. तो तुरंत आप अपने लेफ्ट साइड में हाथ रख के सोचते हो कि हे भगवान ये कौन सा किस्सा है। ओवर द पीरियड ऑफ टाइम आप पेशेंट को सिर्फ यही बोलते हो, जब एक्सपीरियंस आता है तो अच्छा एक काम करो, एक फोटो खींच के भेजो, एंड देन यू रियलाइज कि वेदर यू आर सपोज टू कीप योर हैंड ऑन द लेफ्ट साइड और कीप इट डाउन। जस्ट जोक अपार्ट, टेक अ रेडियोग्राफ, लॉक इट, इफ इट इज सील्ड प्रॉपरली टेक अ ओपन ट्रे इम्प्रेशन। जब आप ओपन ट्रे इम्प्रेशन ले रहे हो तो ध्यान रखना कि जो आपका पट्टी है, आपको पता है यहाँ पे पट्टी है, उससे पाल्पेट करके फील करना। एंड इफ यू आर प्लेसिंग अ मल्टीपल इम्प्लांट दिस बिकम्स अ क्रूशियल एंड क्रिटिकल स्टेप। उसमें पट्टी के सेट होने से पहले जल्दी जल्दी सब जगह पाल्पेट कर लेना। दैट्स व्हाई देयर आर फ्यू इम्प्रेशन एनालॉग, ओपन ट्रे इम्प्रेशन एनालॉग which has further longer screw. And the beauty of again Noble Biocare, this is actually a Noble Biocare design which has been taken by Alpha Bio, is its impression analog top has a projected serration with a thumb screw holding. कई बार ऐसा होता है कि जब आपने पोस्टीरियर रीजन पे इम्प्लांट प्लेस किया है और वहां पे आप ड्राइवर प्लेस कर ही, क्योंकि इमेजिन दिस इटसेल्फ इज अराउंड 16 मिलीमीटर एंड दिस इज 21 मिलीमीटर, 16 plus 21 millimeter. Do you feel it is practically possible for the patient to open mouth? और इमेजिन करो कि उसके कॉन्ट्रालेटरल टीथ और प्रेजेंट है, तो थोड़ा सा मुंह खोलिए ना, थोड़ा सा और खोलिए। That becomes a, means believe me, prosthetic is a very difficult task. You'll come to know. So if you have this knob, what you can do is you can just try to rotate it. कभी कभी ये हाथ से रोटेट नहीं होता, तो इसका जो सरेशन है उसका एक ब्यूटी है कि use a periosteal elevator or use your wax spatula and then just try to rotate it a bit. Once it is rotated, उसके बाद आप हाथ से रोटेट करके इसे बाहर निकाल सकते हो. Another important trick is see to that it should completely disengage. It is always better कि आप इस पिन को पूरा बाहर निकाल दिए हो, उसके बाद ही इम्प्रेशन ट्रे को बाहर निकालने की कोशिश कर रहे हो, क्योंकि एज अ बिगनर आपको ये समझ में नहीं आता कि आपने उसको completely disengage किया है कि नहीं किया है, और ये स्क्रू का छोटा सा हिस्सा लास्ट सेट इम्प्लांट पे जुड़ा रहता है, और कभी कभी आप पेशेंस खोने के बाद उसको तेजी से निकालते हो और आपका इंप्रेशन बर्बाद हो जाता है. अगेन सत्य घटनाओं पे आधारित. ठीक है, सो बी केयरफुल अबाउट दैट पर्टिकुलर स्टेप. कंप्लीटली रिमूव इट एंड देन रिमूव द ट्रे. मेक अ हैबिट ऑफ इट. सो दैट्स इट. And then there are few components which has been kept over here, which I didn't tell you because full mouth rehabilitation is completely different topic and complex in itself. Why? Because when we are talking about a full mouth rehabilitation on multiple, the prosthetic component is different, where we use a multi-unit abutment. अगर आप 2 से ज़्यादा implant place कर रहे हो, you have to use multi-unit abutment. चाहे आप एक आर्च में 3 implant place कियो, use multi-unit abutment. अगर आप 10 साल तक पीसफुली जीना चाहते हो तो. ओके, मल्टी-यूनिट अबटमेंट विल लीड टू एडिशनल कॉस्ट, बट बिलीव मी, जो बाद में जो टेंशन आता है फिटिंग को लेकर, वो सारा चीज बाईपास हो जाता है इफ यू आर यूजिंग मल्टी-यूनिट अबटमेंट. मल्टी-यूनिट अबटमेंट, मल्टी यूनिट एंड अबटमेंट, नेम इटसेल्फ कि above the implant fixture you are placing one more abutment, and on top of it prosthetic part is coming. So that's why it is called as multi-unit abutment. Multi-unit abutment, most of the company, Alpha Bio and Noble Biocare, both has 2 different multi-unit abutment. One is a straight and other is angulated. They have an angulated of 17 degree and 30 degree. 17 degree correction means अगर आपने implant imagine करो कि maxillary anterior में place किया है, so maxillary anterior by default jawbone has a proclination labially, तो उसे prosthesis, अगर आप उसी जगह पे prosthesis देने की कोशिश करोगे तो you will have a opening vent on labial surface of your teeth. और अगर आज के डेट में जो प्रेजेंट इम्प्लांटोलॉजी चल रहा है, जो कि प्रोस्थेटिक ड्रिवन इम्प्लांटोलॉजी है, अगर आपने लेबियल सरफेस पे वेंट दे दिया है तो मान के चलो कि यू आर इन फेलियर. Okay, so there are the multi-unit abutment are basically meant for that. कभी-कभी patient की anatomy ऐसी रहती है कि 17 degree या 30 degree भी चमत्कार correct नहीं कर पाता है. You are supposed to use 30 degree with a modified crown on it. Again, that's a different part which we cannot discuss over here. So I'll just show you two multi-unit abutment which has been kept over here. This is a 17 degree multi-unit abutment. Okay, I'll just show you with this. Can you see that there is a slight tilt towards the lingual side? We gave a slight tilt towards the lingual side because we knew there is a huge amount of concavity. Now, अगर मुझे full mouth rehabilitation करना है तो this change of angulation is tricky and troublesome. So what I'll do is I'll use this multi-unit abutment, 17 degree multi-unit abutment for angle correction. Okay, for angle correction. For angle correction. This is to be used when you are using implant more than 2. एक implant, दो implant, don't use it because this itself has a different task क्योंकि आपके soft tissue की height compromise होती है. So that's all about implant placement and its prosthetic component. Any kind of doubt or do you want me to show something else? क्योंकि अभी ऑलमोस्ट सबके सब हाइपोग्लाइसेमिक हो गए होंगे, कुछ लोगों को चक्कर आ रहा होगा और सुनना तो पिछले 2 घंटे से ही बंद हो गया था क्योंकि बॉस बैठे हुए हैं इसलिए मजबूरी में सब मजबूरी में सब बैठे हुए हो. So if anybody is having any kind of doubt, we'll take 5 more minutes for discussion and then we'll discuss that. Any doubt? Yeah, no doubt means सब कुछ ऊपर से गया है. यार अभी तो समझा है नो डाउट मतलब सब कुछ ऊपर से गया और तू हाथ उठा रहा है. प्लीज. धन्यवाद भाई, आगे बता. मुद्दे पे आ, समय नहीं है. आइडेंटिटी एक्टिव इम्प्लांट आप ये मान के चलिए कि इट्स ऑल अबाउट थ्रेड डिजाइन. एक्टिव इम्प्लांट वो सारे इम्प्लांट्स हैं जिसके थ्रेड्स में अपने आप एकदम सिंपल से लेमैन लैंग्वेज में बात करूं, हार्डवेयर की दुकान गए हो? हार्डवेयर की दुकान गया है? कभी आपने स्क्रू खरीदा और कभी आपने खीला खरीदा? खीला खीला पैसिव है और स्क्रू जो है वो एक्टिव है. इट मीन्स एक्टिव जो है वो खुद बोन को स्क्रू करते हुए टाइट करते हुए अंदर जा सकता है. पैसिव में आपको ऑस्टियोटोमी करना पड़ेगा, उसमें उसके थ्रेड्स में सेल्फ टैपिंग के फीचर्स नहीं रहते हैं. सो दैट इज कॉल्ड एज एक्टिव एंड पैसिव. थैंक यू सर.
Sir, how are we going to determine the gingival collar height?
How we are going to determine the
By
gingival?
giving a healing cap, how are we going to determine what is the dimension of a healing cap?
Yes. I have my publication, which is there in Dr. Rangarajan's textbook also. Just go and read it.
Okay,
Sorry, joke apart. Simple thing is there are different way to determine. Let's talk about the practical way and let's talk about the theoretical way. Theoretical way is use of the different techniques which has been given in textbook कि आपने उस जगह को एनेस्थेसाइज किया और उसके बाद आपने हाँ जिंजाल मैपिंग किया. एग्जैक्टली जिंजाल मैपिंग मतलब आपने एंडो फाइल्स वगैरह लेके आपने जिंजाल की हाइट वगैरह डिटरमाइन की. दैट इज लिटरेचर वे. प्रैक्टिकली हम लोग वो कुछ नहीं करते हैं. एक बार एनेस्थेशियन 2 बार थोड़ी एनेस्थीसिया दिलवाएगा. तो सिंपल वे इज टेक लिटिल बिट हायर साइड ऑफ कॉलर हाइट. जो अबटमेंट आपने लिया है उसका सिंपल सा रूल ये याद रखना कि आपके पास एक रेंज ऑफ हीलिंग अबटमेंट रहना चाहिए. ट्रायल एंड एरर पे प्लेस करते चले जाओ. 2 मिलीमीटर, 3 मिलीमीटर, 4 मिलीमीटर, 5 मिलीमीटर. जिस हाइट का आ रहा है दैट इज उसी हाइट के मतलब हीलिंग अबटमेंट के आपको गाइड करेगा प्रोस्थेटिक अबटमेंट के सिलेक्शन को. नाउ व्हेन वी आर टॉकिंग अबाउट प्रोस्थेटिक अबटमेंट हैज अ डिफरेंट कॉलर हाइट. तो उस कॉलर हाइट को कैसे डिटरमाइन किया? आपने जो हीलिंग अबटमेंट प्लेस किया था ना उस बेसिस पे आप डिटरमाइन करोगे. So that will help you to judge. Now, when we are talking about multi-unit abutment, this is different picture. When we are talking, especially in case of full mouth rehabilitation, because in full mouth rehabilitation, it is always wise कि multi-unit का जो platform है, वो जिंजावा के कम से कम 1 मिलीमीटर या 0.5 मिलीमीटर नीचे होना चाहिए, ना कि ऊपर. तो अगर आप 0.5 मिलीमीटर नीचे रख रहे हो, तो there is something called as dummy multi-unit abutment check. I don't remember the name exactly, but it is available both with Noble Biocare and Alpha Bio. So basically, it's like how we have a shade tabs. Similarly, वो multi-unit abutment के अलग-अलग collar height का आता है, because multi-unit abutment is an expensive affair. उसमें आप trial and error पे नहीं कर सकते. So you just place it, check कि okay, now this one, what you need is a 17 degree, 1.5 collar height. You request your assistant to open multi-unit abutment, 17 degree, 1.5, open, place it. अगर आपने next step place किया जिसमें 2.5 आ रहा है, you request your assistant to open that tab, क्योंकि एक बार खोलने के बाद उसका स्टरलाइजेशन खत्म हो जाता है. हालांकि हम इस हिंदुस्तानी उसको वापस ऑटोक्लेव में डाल के नेक्स्ट पेशेंट के लिए रख लेते हैं, बट यू आर नॉट सपोज टू डू दैट. सो दैट्स फॉर द मल्टी यूनिट अबटमेंट. सी, नॉर्मल 1 unit, 2 unit, it is straightforward healing abutment. But if it is multi unit abutment you are placing, then in that case there is a tool, and there are few local Indian manufacturer. I remember Jalandhar Surgical. There is a next time किसी कॉन्फ्रेंस में जाओगे तो स्टॉल ढूंढना जलंधर सर्जिकल का. उसके पास ना मल्टी यूनिट अबटमेंट के कॉलर हाइट का टैब्स रखे हुए हैं. तो सर्जरी के वक्त आप उस टैब को प्लेस करो, वो आपको गाइड करेगा कि कौन से हाइट का मल्टी यूनिट सेलेक्ट करना है.
Thank you. And there's one more question, sir. Angulation कैसे determine करें multi units का for multiple implants?
I didn't get you, बेटा.
Sir, how do we determine the angulation while placing the multi unit abutment?
Yes. How do we determine? It's simple. कवर स्क्रू प्लेस करने के बाद आप इसको प्लेस करो. विथ एक्सपीरियंस आपको समझ में आ जाएगा कि 17 डिग्री लगना है कि 30 डिग्री लगना है. अदरवाइज मान के चलो कि आपको दोनों खोलना पड़ेगा, और चूंकि आप स्टूडेंट हो तो एडवांटेज ये है कि आप उसको ऑटोक्लेव करने के लिए डाल सकते हो. इट्स ट्रायल एंड एरर, दैट्स ऑल आई कैन से. अदरवाइज वो जो टैब है, उस टैब से आपको एग्जैक्टली पता चल जाता है कि पैरेललिज्म कितना आ रहा है. या फिर जब आप इम्प्लांट प्लेस करते हो तो इम्प्लांट के ड्राइवर को देखकर ही समझ में आ जाता है कि इट इज अराउंड 17 डिग्री और इट इज मोर देन 17 डिग्री. और कुछ चमत्कारिक लोग जो हैं वो 30 डिग्री के ऊपर का भी टिल्ट देते हैं, विच यू आर नॉट सपोज टू डू, बिकॉज इफ वी रीड अबाउट ऑल ऑन 4 कॉन्सेप्ट, बियॉन्ड 30 डिग्री, बियॉन्ड 45 डिग्री, नॉट सॉरी, बियॉन्ड 45 डिग्री इट कॉसेज हार्मफुल इफेक्ट ऑन टिल्टिंग. जैसे हम टिल्ट इम्प्लांट के बारे में बात करते हैं तो अ परमिसिबल लिमिट इज 45 डिग्री. अगर आप 45 डिग्री से ज़्यादा दे रहे हो तो इट कॉसेज अ रिवर्स इफेक्ट एंड इट कॉसेज अ बोन रिजॉर्प्शन ओवर द पीरियड ऑफ टाइम. लाइक यू मस्ट हैव सीन कि nowadays there are multiple implant company who are coming with 55 degree multi unit abutment, 85, I think some implant company is having a 75 or 65 degree of multi unit abutment. Don't blunder the implantology. Imagine करो कि आप 65 डिग्री का एंगुलेशन दे रहे हो, इसका मतलब आप इम्प्लांट सुलाई दे रहे हो वहीं पे. वर्टिकल में बोन नहीं है, आपने ऐसे सिर्फ 8 मिलीमीटर में ऐसा टिल्ट. नो, 30 डिग्री इज स्टैंडर्ड एंड देयर इज अ गुड अमाउंट ऑफ लिटरेचर विच सेज 30 डिग्री. देयर इज नो नीड ऑफ टिल्टिंग मोर देन दैट. इफ यू आर टिल्टिंग मोर देन दैट देन यू आर इन ट्रबल आफ्टर अ लॉन्ग पीरियड ऑफ टाइम. लॉन्ग पीरियड ऑफ टाइम मतलब 2 साल 3 साल बाद आपको वहाँ पे दिखना चालू हो जाएगा कि आपने जो चमत्कार किया है उसके परिणाम दिख रहे हैं. बस भाई, खाना नहीं खाना है.
वन लास्ट सर, आपने बोले कि पहली बार वो लिगामेंट ड्रिल के बाद फर्स्ट ऑस्टियोटोमी करने के बाद वी हैव टू पुट अ डायरेक्शनल पिन टू चेक द एंगुलेशन.
लिगामेंट ड्रिल के बाद आपको 2 mm वाला ड्रिल यूज करना पड़ेगा. क्योंकि आप डायरेक्शन इंडिकेटर का डायमीटर देखोगे तो दैट्स 2 मिलीमीटर. लिंडरमैन के बाद आप कभी उसे प्लेस नहीं. लिंडरमैन का बेसिक फंक्शन है कि जो डेंस कॉर्टिकल बोन है उसको पंक्चर करना.
तो 2 मिलीमीटर के बाद जो हम लोगों ने डायरेक्शन पिन लगाए, आपने बोले कि उसके बाद एक IOPR लेके देखने के लिए कि डायरेक्शन ठीक है नहीं. तो सर IOPM में हम लोगों को तो मीडियोलैटरल जो डिस्टेंस है वो पता चलेगा. Is there any way to determine if we are in a correct angulation for buccolingual also?
Improve your implantology, that's all I can say.
Okay sir, thank you.
Thank you so much, sir, for such an inspiring and insightful session. Your vast experience and knowledge in the field of implantology have truly enriched us. Now, I would request Professor Dr. Abhishek De Sharkar, sir, to kindly felicitate our speaker. Please put your hands together while we have the felicitation. Thank you so much. To conclude this enriching session, I would now like to invite our Joint Organizing Secretary, Professor Dr. Shayan Mojumdar, sir, to deliver the vote of thanks.
Afternoon. It's my privilege and honor to deliver the vote of thanks on this special occasion. First and foremost, I would like to express our sincere gratitude to our principal, sir, for his constant encouragement and leadership and support. And we are thankful to our hospital superintendent, sir, for his encouragement and support. We are also deeply thankful to the management who has provided the platform for organizing such session. To our distinguished speaker, thank you for sharing your valuable insights, and we are immensely grateful to our sponsors for their generous support that have been crucial in making this event a reality. Finally, I wish to acknowledge the dedication of the organizing committee, the enthusiastic participation of the attendees, hard work of the volunteers and the office bearers, whose collective efforts have ensured the success of these events. Thank you.
Thank you all. I hope we'll be conducting more such enriching sessions in the future.